পম্পা 2012 ডট। Good afternoon. Good afternoon.
Hello.
Hello. Hello, hello. আমি ডক্টর সুবোধ ভট্টাচার্য। হ্যাঁ, সেশন 2টো থেকে শুরু হবে। অঞ্জন কুমার দাস। কথা বলে সব কিছু শোনা যাবে না? বলছি কোনো কিছু বলতে গেলে এটাকে মিউট আছে? আনমিউট আছে।
ল্যাপটপে চার্জার ইউজ করবে তুমি? তোমারটা?
না 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 এটা এরকম কেন আসছে?
ও কোথাকার ফটো? হ্যাঁ হ্যালো, দেখা যাচ্ছে? হ্যাঁ হ্যালো, হ্যালো, আমি সুবোধ ভট্টাচার্য বলছি, আমি আছি কিন্তু।
হ্যাঁ স্যার,
হ্যাঁ স্যার,
আপনাকে দেখা যাচ্ছে স্যার, স্যার
দেখা
দেখা
যাচ্ছে, শোনা
যাচ্ছে।
যাচ্ছে।
ঠিক আছে, থ্যাংক ইউ।
ওয়েলকাম স্যার।
হ্যাঁ কতক্ষণে শুরু হবে? প্রায় আর 5-10 মিনিট না আরো বেশি? শুনছেন?
স্যার হ্যালো স্যার, ওকে স্যার, we are all in actually. Okay sir, I'll yeah. Sir, you have informed him, right? Then I'll talk to him, sir, once more. Okay, sir. Okay, sir. So, yeah, sir, I'll let you know. Yeah.
If all the judges and participants for hematology session are present right now, please go ahead. Deepak Mishra sir has already joined.
Sir, shall I start, sir?
Yes, please proceed. Yeah.
I have also joined. You can start.
Okay. So, good afternoon, everyone. I, on behalf of the organizing team, welcome everyone to a post-lunch session. So, we'll proceed with our award paper session for hematology, cytology, microbiology, and free paper presentation. Gaurav, the slides are not changed. Okay, so first I'll explain the basic rules for presentation. All the presenters should have good broadband connection. Keep your camera off and mic muted when not speaking. The total duration of presentation is 10 minutes. The reminder will be given by me at 6 minutes plus 1 minute, and the question answer session will be for 3 minutes. So we'll move on with our first session, that is award paper hematology. I would like to introduce our esteemed panel of judges, Dr. Deepak Kumar Mishra sir, Dr. Pradeep Mitra sir, and Dr. Shubhat Bhattacharya sir. Dr. Deepak Kumar Mishra sir is the Director of Pathology at Tata Medical Center, Kolkata. Dr. Pradeep Mitra sir is the COVID Coordinator of West Bengal and ex-Director of Medical Education, West Bengal. Dr. Shubhat Bhattacharya sir is the Dean and Principal of Gauri Devi Institute of Medical Sciences and Hospital. So I have explained the rules, and all the presenters keep on your video and mic when you're presenting. So I'll start with the first presenter, Dr. Aparna Shah. She is a second-year postgraduate trainee of Medical College, Kolkata. Her topic, hematological parameters in COVID-19, a retrospective study of 50 patients in a tertiary care hospital in Eastern India. Dr. Aparna? Dr. Aparna? Dr. Aparna, you're there. Can you hear me? Dr. Aparna, unmute your mic.
Hello. Hello.
Yeah, Aparna, you're audible.
Please confirm me, is there video is working or not? Actually,
No, video is off. Video is off. You have to switch on your video and start your presentation. Deepak da, hello.
can you hear me?
Yes, you're audible.
And video is sure or not?
Video is off, but I think you should start your presentation.
Good afternoon, everyone.
No, your presentation is not visible. Deepak da, can you help her?
Okay, just hold on.
Am I audible? Can you hear my voice?
Yes, sir, you're audible.
Hello. Hello.
Just hold on. Just hold on. I think this is the. Is this the PPT?
Yes, yes, yes.
Yes. Can you see now, Dr.
Yes.
Aparna?
Yes, yes.
Okay, you will say me when you want to move the slide. Just say next. Okay.
Okay, okay, sir. Okay, sir.
Okay.
Today's topic is hematological parameters in COVID-19, a retrospective study of 50 patients in a tertiary care hospital in Eastern India. Next, my introduction. Next, recent pandemic of COVID-19 has a major public health and economic impact caused by a severe acute respiratory syndrome coronavirus 2. The transmitted rooted are direct contact, droplet, airborne, and fomite transmissions. The common noted clinical features are cough, fever, dyspnea, myalgia, anosmia, ageusia, and diarrhea. The clinical spectrum ranges from the asymptomatic carrier to the severe bilateral diffuse pneumonia, leads to ARDS, respiratory failure, multi-organ failure, dysfunction. The hematological features reported are leukocytosis, neutrophilia, lymphopenia, and thrombocytopenia. Objective: to determine the hematological parameters, total leukocyte count, absolute neutrophil count, absolute lymphocyte count, and the platelet count in COVID-19 patients, and compare them between the discharged patients and the expired patients, and also to look at any association between these parameters and the number of days of hospitalizations. Method and materials: it is a retrospective observational study conducted in a 50 COVID-19 artificial confirmed patient admitted in our institutions during the period of July to September 2020, and the statistical analysis done by the Graphite Prism 60M, the sick p-value of the less than 0.05 considers as the statistically significant. The exclusion criteria are the any pediatric age group, any immunodeficiency disorder, and the malignancies. And the sample collection. The patient's particular relevant history and the hematological parameters are to be studied or obtained from the medical records. Patients are then divided into the two broad categories, Group A and Group B. Group A are discharged from the hospital after recovery, and the Group B are the expired at the hospital. And Group A further subdivided into the two groups based on the days of hospitalization. Group A1 equal to less than equal to 10 days, and Group A2 greater than 10 days. The cutoff of the high TLC and ANC and low ALC and the PC are 11,000, 8,000, 1,000, and 1 lakh per millimeter cube respectively. Next, the values are expressed as a mean and range. The variable are compared by using the unpaired t-test, and the categorical variable are expressed as the percentage and compared using Fisher exact test and chi-square test. The result: in our study, populations has a male predominance, and we observed that the average days of hospitalization are the more in the younger populations, but the fatality rate is more in the higher age group. Please show the tables as we see in the table 1, TLC of A1 and A2 are 6,907 and 10,207 respectively, and the mean ANC value are 5,659 and the 8,509 per millimeter cube as for the Group A1 and Group A2 respectively. These findings are evident that the leukocytosis and the neutrophilia are strongly associated with the increased number of days of hospitalizations, and the mean TLC and the ANC is 18,001, 14 per millimeter cube and 16,235 per millimeter cube, for strongly suggestive of the septicemia or neutrophilia as one of the most important pathophysiology for the worst outcome. The ranges of mean ALC is 1,559 and 822 in case of Group A1 and in A2 respectively, and the ranges of ALC is 452, 1,792 and 3082 2100 per millimeter cube for the above said group. So the lymphocyte count decreases, the severity of the disease process increases. Please next. In our study shows the NLR is a very crucial factor for the disease course. Next, and the outcome is the higher of the value of the NLR is that increase the days of hospitalizations and the death may occur. Please next recommendation periodic. Previous slide, please. The periodic routine CVC and the inflammatory parameters may predict the severity and the NLR and the monitoring for the better prognosis. Next. Discussion. Patients who expired are significantly of the higher age group than the who were discharged, excluding the sex of the patient. Other studies also have the same results. In our study, we also found that the patients of group A2 and the B has significantly higher TLC and ANC compared to the other group A1. In this study, patients in the group A2 show significantly lower ALC compared to the group A1. One et al. Also reported the lymphocytopenia needing more ICU admission and the mechanical ventilation and death. Conclusion. Death, high TLC, high ANC and the low ALC predict the worse outcome. No association between the platelet count and the outcome in our study. The study can also help in as a prognostic purpose as these parameters are cheap and easily available, having the specific relevance to the resources, constant environment like underdeveloped countries. Next, there is some references for my studies. Thank you all.
Thank you, Aparna. Now,
Am I
Pradip,
audible, sir?
yes,
Yes,
you
you're
are
audible.
You are you able to listen to me? What I'm asking, I'm saying.
Yeah, sir.
So Pradipda is in the judge.
Yeah.
Would you like to ask anything before I ask a couple of questions?
I'd like to ask one thing that in the exclusion criteria, she has said that immune deficiency disorder. By that, what exactly she meant for that? What are the cases she has kept outside this study? Disorder or any condition of immune deficiency? What you have kept outside?
So like any kind of infections like HIV and the other malignancies like pre-diagnosed before the admissions.
Oh, so you mean to say in all of them you looked for the HIV screening before including the study, including the in your cohort?
That's the point. So
you randomly took 50 patients within a certain specified period of 6 months.
Yes, sir.
Okay, I don't think you considered the HIV screening as part of the exclusion criteria. You
Right.
must have just the history that you have the patient is HIV negative.
Sir, as it's a retrospective study, I had taken all the informations from the patient's BHT. So if there is any kind of immunodeficiency disorder or any previous like HIV or HBsAg positive like patients, so they are written already.
Historically, you excluded, not by doing the test.
Yes, sir. Yes, sir.
okay, one thing is have you considered severe uncontrolled diabetes with insulin patients in this group? Or have you taken into consideration anything about that? Separately?
Sir, yes, some patients have comorbidities like diabetes mellitus and hypertension, and some patients were in insulin also.
That's right, but this is a flat study, and actually, have you considered that this type of serious comorbidity can affect these accounts and all these things, apart from the COVID?
Yes, sir, it can, but it's already COVID artificial positive. That's why we had
You
taken.
have considered only the COVID status, yes.
Exactly. Sir.
Anyway, Dr. Mishra.
Yes.
You can.
First few observation is you spoke so rapidly, it appeared that you are running against time. You see, you should take some pauses in between to emphasize certain aspects. So you just, but it was like a Tufan Express. You just started and rattled the slides in one breath without taking any pause. So that is one thing. So whenever
sir,
I know
sir,
they have
actually,
given you
I
very little
panicked that I
time.
can't share the screen. So I thought time
No,
is going on.
no,
Anyway,
no, that,
just
yes,
an
that is,
that
but
was
that point has not been counted. That
that is
period.
an observation. Now, Aparna, tell me, your study is very, very basic. You just took
Sir.
parameters.
Yes, sir.
Total leukocyte count, total the absolute lymphocyte count, the absolute neutrophil count, and the platelet count.
Yes, sir.
Just 4 parameters you have studied in this 50 patients.
Yes, sir.
But
Along with the
and you have excluded and discussed the mortality rate, the morbidity rates based on these 4 parameters. You know, once you are talking about hematological parameters, you should have spoken a little bit about CRP, spoken a little bit about the IL-6, you have spoken a little bit about the coagulable states, the PTA, PTT, and in case there is anything other studied. So if you have included those variables to discuss about the possible and the other comorbidities, what Pradipta has asked, whether the patient is diabetic, whether the patient is hypertensive, whether the patient has prior history of coronary artery disease, any COPD, anything. So all those would be very important along with these hematological parameters.
Yes, sir. But, sir, I had taken all the histories, but though it's a very small time and a small paper, it's an ongoing project. I had taken all the measurement like CRP values and the comorbidities values.
If you do not include other parameters, it will not get published anywhere in a standard journal. Just on the basis of 4 hemocytometry parameters. Okay, so if you want to make the study broad-based, please include all those things. Include all the other variables that can cause morbidity and mortality in COVID patients.
Right.
Otherwise, well tried. You spoke well. You are fluent. Everything was nice, and we congratulate you for being
Thank
here
you, sir.
to present today. And I, on behalf of Pradipta and my other co-chair Subodha, congratulate you.
Right.
Yes, sir. Thank you.
this
Thank you
in
so much, sir.
the,
Sir, I will work on what you said.
yes,
Sir,
yes.
definitely.
You must include, otherwise it is very, very basic.
this.
Sir, actually, my thesis paper was also on that. So I will include all of these things in my thesis paper.
So
Thank you.
retrospective study only by 50%.
Hello.
Yes, should we go to the next presentation?
Okay, sir. Dr. Pratyush, are you there?
Yes, I am.
Okay. Okay. So our next presenter is Dr. Pratyush Datta. He's a first-year senior resident at ESI PGI MSR. The topic is antenatal screening for beta thalassemia with mutation analysis in cases. So Pratyush Datta, you can start your presentation.
Okay. My presentation is visible, no? Am I audible also?
Yeah, you can start.
Hello? Yeah, okay.
Yeah, you can start.
Good afternoon, respected judges and learned audience. My topic is antenatal screening for beta thalassemia with mutation analysis in cases having borderline HbA2 level. Beta thalassemia major is the predominant cause of transfusion-dependent severe anemia in the world. The patients often need blood transfusion and iron chelation therapy. Definitive treatment is allogenic BMT, which is often beyond scope due to its high cost, lack of infrastructure, and medical complications. So to prevent the birth of beta thalassemia major individuals, carrier screening is the procedure of choice. It can be carried out at different level, like in adolescents, like in preconceptual, premarital level, as well as in antenatal level. Now, the advantage of antenatal carrier screening is that the couple can be offered genetic counseling, and if the fetus is found to be beta thalassemia major, it can be selectively terminated if medically and legally permitted. Now, the genes responsible for beta thalassemia phenotype resides in the chromosome number 11, and the mutations responsible may be point mutations, may be insertions, deletions, as well as splice junction defects. Almost 300 beta thalassemia mutations has been discovered all over the world, out of which 50 has been found in India. These are the examples of some common Indian beta thalassemia mutations. Now, our objective was detection of occurrence of beta thalassemia traits among the antenatal mothers, detection of occurrence of beta thalassemia mutations in cases with borderline HbA2 value. We have taken 3.5 to 3.9% as the borderline value. Now, screening of husbands of beta thalassemia traits for beta globin mutations was our third objective. This is a hospital-based prospective observational study carried out at the Department of Pathology, ESI PGIMSR Maniktola, and the study period was September 2019 to August 2020. Inclusion criteria: women registered at the antenatal clinic, irrespective of age and trimester, and husbands of the beta thalassemia trait mothers. Exclusion criteria was patients with history of blood transfusion within last 12 weeks were excluded from performing HPLC. Now, we have collected 2.5 ml EDTA blood and 4 ml clotted blood from the patients. The clotted blood was subjected to biochemical analysis, and with the EDTA blood, we have done HPLC with a Biorite D10 system and have extracted DNA from it with a proprietary kit known as the beta globin strip assay IMA kit, which is a reverse hybridization based line probe assay system, and detected the beta globin mutations. This kit is CE and IVD approved, and based on reverse hybridization of biotinolated PCR products, it combines probes of variants and controls in a parallel array of allele-specific oligonucleotides, work with immobilized oligos on a test strip, and generate test results by enzymatic color reaction easily visible to the naked eye. It does not require any special software, any specially trained personnel, specialized lab, and utilizes very less manpower. After DNA extraction, there are 3 steps: amplification, hybridization, identification, which all can be completed within 6 to 7 hours only. Now, these are the different instruments we have used. This is the extraction of DNA of EDTA blood done in this cabinet with proprietary extraction chemicals. In the next step, the amplification by thermocycling was done by a Biorite CFX96 touch system. And the third stage of the stage of color development, we have used shaking water baths, orbital shakers, and steps including washing. Then the nitrocellulose strip in which the purple pigment was appearing, represented over here, it has a control line. It has mutant lines and wild type lines as well. The mutant, there are 22 mutant lines, and which represents the most predominant mutations found in the Indian region and the Arabic Peninsula region, as seen in the green circle. There are 2 more such strips available. One is specific for Mediterranean zone, another is for Southeast Asia. Now, how to interpret? If on the strip only the wild type line is visible, that is positive, then the genotype is supposed to be normal. If both the lines, mutant or wild types, are visible simultaneously, then the genotype is supposed to be heterozygous. If more than one mutant line is visible, then the individual is a double heterozygous. And if only the mutant line is visible, then the patient is homozygous mutant. Now, out of this, in the stipulated time period, we have got 367 antenatal women, out of which 16 were having beta thalassemia traits, that is HbA2 level 4% to 7%, and 15 were having borderline HbA2 level, and making the total individual in these 2 groups 31. We have called upon the husbands of the beta thalassemia trait mothers. 13 responded, making the total cases evaluated for beta globin mutation to 44. Out of these 3 categories, we have found mutations only in antenatal females having beta thalassemia trait. Neither any husband nor any female having borderline HbA2 level were detected with any mutation. Now, this is the distribution of hemoglobin in cases evaluated for beta globin mutation. In this cohort, in which we have found the mutation, the HbA2 level was 4.2 to 6.1%, and one case having 23.9% sickle anemia, sickle hemoglobin, was later detected to be a double heterozygous case. Now, IVS 1.5 G2C was the commonest mutation detected in 81.25% of the traits. Other mutations were codon 15, codon 30, and one case, as mentioned earlier, was double heterozygous. Now, our findings of our study was concordant and discordant with various previous studies, but we have to compare it with caution, because maximum of those studies have used variant 2 as the HPLC detection system, not the D10 system. Neither they have used the beta globin strip assay as the mutation detection mechanism. Now I am going to present some significant cases. This is a case with HbA2 level 3.4%, where all the wild type lines are visible, but no mutation line. So there is no beta globin mutation. In this case, there are wild type lines as well as one mutation line for IVS 1.5 G2C. The HbA2 level was 5.3%. Now, this is the double heterozygous case where two simultaneous mutation lines are visible. The HbA2 level was 4.2%. So the limitation of my study was limited sample size, as the study had been conducted exclusively on individuals under ESI coverage, and limitation to detect only 22 beta globin mutation by beta strip IME. So beta globin strip assay IME is a technologically less demanding, less labor and time intensive, effective, and comparatively cheaper alternative to other mutation detection methodologies, which can be utilized for antenatal diagnosis of beta thalassemia. These were my references. Thank you all. Hello.
I think it's a wonderful presentation. You presented really well. Now
Thank
I
you,
would
sir.
like
Thank you, sir.
Professor Pradeep Mitra to take over with a couple of.
Yes, my impression also is that he has Professor presented wonderfully, very good presentation and very good work.
Thank you, sir.
Actually,
Thank you, sir. Thank you, sir.
And that is good. Only thing I can ask, you have given the references. It is not possible to see all the references. It's a long chat. Just I'm going to ask you, where from you have got this borderline, because you have taken 3.5 to 3.9. So is there any specific reference or any other reference where from you get this borderline variant, borderline?
Sir, in some of the studies, we have found that the range of borderline value was different in different studies. Some have taken 3% to 4% as the borderline. Some have taken 3.1 to 3.9 as the borderline. But in some Indian studies, we have found that 3.5 to 3.9, and it was more suitable for us to use this as the borderline system.
That I know. That's why I'm asking, because there are variations. But in some Indian studies, they have taken the borderline case as 3.5 to 3.9. So can you name who has studied this? Where from you get the reference?
Sir, I just
anyway.
I could not remember right now, sir.
Anyway, another thing. Yes, it's a very good case. I should suggest you to go on or continue some other with more samples, because it's an eye opener, because in none of the samples you have got mutations in the borderline cases. So that's why that may detect that the value may be raised to 4 or beyond 3.9 in Indian cases. So that is an indication. So anyway, over to Dr. Mishra.
Good performance, sir. Good presentation.
Thank you. Thank you.
Both of us have already reiterated that you really presented well. Your data is very good. You were very crisp, very concise, and your presentation skills were very good.
Bhattacharya would like to say something, because he has
his presentation is good, and he has done the beta globin strip assay in his college, Joka. That is very good. This facility is not available in our any college, state government. Huh?
Absolutely.
Sir, I am from ESI Maniktala, sir. It's done in ESI Maniktala.
That facility available in your center. This is not available in our any college. You have done well, but only the sample size is very small. 300 is
yes, sir. The sample size is really small. Sir.
Very small.
I admit that, sir.
Very good.
As part of the National Thalassemia Screening Program, checking antenatal mothers is one of the strategies to contain the disease.
Yes, sir.
Your study size is low, so I have two questions. What have you done to test the normal HbA2 beta thalassemia carriers, or what you call as silent beta thalassemia carriers?
Yes, sir. Silent beta thalassemia carriers are those, sir, who have not any phenotype in them. That is the MCV, MCH, HbA2 level all remains within the normal limit, but the mutation can be detected in them. So I have also tried to detect silent mutations here but neither in any borderline case nor in any husband, that is with all the normal level HbA2 level, any mutation could be detected. But the limitation may be due to that, sir. This strip I have used consists only 22 mutations, sir, and these mutations may not exert the silent phenotype. This is the most predominant mutation in this Indian and Arabic Peninsula population, sir, and these mutations are maximum beta plus phenotype of beta plus phenotypes and not of silent phenotypes. If we could detect the silent phenotype, that would be really helpful, sir.
Okay. The other thing is that hemoglobin A2 is often increased if you have megaloblastic anemia.
He has mentioned.
Folic acid deficiency in pregnancy is very common in India.
Yes, sir. Yes, sir.
So you will also have some degree of megaloblastic change in the erythroids, where the MCV will get upset. It will not be microcytic hyperchromic, but it may be normocytic normochromic because of presence of iron deficiency as well as megaloblastic.
Megaloblastic simultaneously, yes, sir.
So hemoglobin A2 can also rise in the presence of megaloblastic. You may get a little borderline HbA2 when you have megaloblastic anemia. Sometimes people say that if you have iron deficiency, you may have subnormal hemoglobin A2. So once you correct the iron, the hemoglobin A2 rise. But that number of papers from India has come out, which has suggested that correction of iron deficiency hasn't affected the hemoglobin A2 levels to a significant extent to suggest that first correct the iron deficiency and then retest them for hemoglobin.
Yes, sir.
So it's not otherwise, you have done a good job. Your numbers, I know this must be your MD thesis.
Yes,
from the MD thesis point of view, this is an excellent study. And I
Thank you,
hope
sir.
all my co-chairs will agree that you have done a good job.
He has done good. His performance is very nice.
Exactly.
Thank you. Thank you, sir.
Ankita.
Okay, sir. Thank you, Dr. Pratyush and Dr. Aparna, for a wonderful presentation. And I thank you all our respected judges for your valuable time and thoughts. So here we have come to an end for our first session. Now we move on to our second session, that is award paper in cytology. So I'd like to introduce our respected judges, Dr. Syed M. Nadim, sir. Sir?
Can I sign off?
Dr. Syed M. Nadim, sir, Dr. Rajat Anand Gopal Mukherjee, sir, and Dr. Anjan Kumar Das, sir.
Huh?
Dr. Hello.
Ankita, should we log out?
Yes, sir, you may log out.
Okay.
Thank you. Thank you, Ankita.
Thank you, sir. Dr. Syed M. Nadim, sir, is the president-elect of West Bengal Cytology Society, and he is the lab director of Neelam, the Complete Care, NG Medicare. Dr. Rajat Anand Gopal Mukherjee, sir, is the zonal head of Metropolis Healthcare. Dr. Anjan Kumar Das, sir, is the professor and head of Department of Pathology of MJN Medical College, Coach Bihar. So once again, I'll explain the rules. The total presentation will be for 10 minutes. I'll give a reminder at 6 minutes plus 1, and the question answer session will be for 3 minutes. So our presenter, Dr. Subarga, are you there? Dr. Subarga, are you there?
I am present.
Okay, fine.
Am I audible?
Dr. Subarga Mandal is a third-year postgraduate trainee in the Department of Pathology, Neel Ratan Sarkar Medical College, Kolkata. The topic is to study the utility of cell block in the diagnosis of primary lung carcinoma. Dr. Subarga, you may start your presentation.
Good afternoon, respected judges and the learned listeners. Today I am going to present my paper on the topic to study the utility of cell block preparation from aspirated sample in the diagnosis of primary lung carcinoma. Lung cancer is a major health problem. It is the second most common cause of cancer death worldwide. Hence, early diagnosis is of utmost importance. Here comes the role of FNAC, which is less invasive, has lower complication rate, and provides early diagnosis. Accurate diagnosis, including morphological, immunohistochemical, and molecular characterization, is necessary and in quick time. Here comes the role of cell block preparation. Architectural preservation suitable for immunohistochemistry are its benefits. These can be archived for future use. We used a panel of immunomarkers comprising of TTF1, P63, and synaptophysin. Such studies on the utility of cell block are more or less rare in Eastern India, and this study wishes to fulfill this lacuna. What were the aims and objectives of this study? To diagnose cases of lung carcinoma from smears prepared for CT-guided aspiration material, to prepare cell blocks from the same and perform microscopic examination, to study the expression of TTF1, synaptophysin, and P63 on the sections thus obtained, and to ascertain the sensitivity, specificity, positive predictive and negative predictive value when this method is compared with histopathological examination of corresponding biopsy materials. Now coming to the methodology. This study was conducted in the Department of Pathology, NRS Medical College for a duration of 18 months. It was an institution-based, prospective, observational, and analytical cross-sectional study consisting of 120 patients who met the following inclusion and exclusion criteria. Patients with unifocal lung lesions diagnosed radiologically as primary lung carcinoma undergoing CT-guided FNAC and having subsequent lung biopsies were included in this study. Patients with multifocal or metastatic diseases were excluded. Cystic fluid and paucicellular aspiration material was also excluded. Certain diagnostic criteria was used for cytology and immunohistochemistry. Smears with malignant cells were regarded as positive for malignancy. Atypical or suspicious cells were regarded as suspicious for malignancy. Smears with no tumor cells or without nuclear atypia were considered as negative for malignancy. An abbreviated panel of immunomarkers comprising of TTF1 for adenocarcinoma, P63 for small cell carcinoma, and synaptophysin for small cell carcinoma was used. Appropriate positive and negative controls were used. Positive control for TTF1 was thyroid tissue. Positive control for P63 was skin. Positive control for synaptophysin was pancreatic tissue. Strong positivity of one or more immunomarkers from this panel was considered positive for malignancy. After statistical analysis, we found the following results. 61 to 71 age group comprised maximum number of patients with the lung lesion. 66% of the patients were males. Male smokers comprised maximum number of the population of, and there was the increasing incidence of lung carcinoma in female non-smokers. Lung adenocarcinoma was the major subtype of lung carcinoma in our study. When we compared conventional smear with cell block with HNE and cell block with IHC, we found that 31% of suspicious of malignancy cases which was found in conventional smear was reduced to 19.2% cases in cell block with HNE and 0 with cell block with IHC. 87.5% cases of adenocarcinoma were TT1F1 positive. P63 positivity in cases of small cell carcinoma was 79.2%. 91.6% cases of small cell carcinoma was positive for synaptophysin. When we compared cell block with immunohistochemistry with histopathological diagnosis regarded as gold standard, we found sensitivity to be 95.4%, specificity to be 91.2%, positive predictive value to be 96.5%, and negative predictive value to be 88.6%. Here we see conventional smear of adenocarcinoma, cell block of adenocarcinoma, TTF1 positivity on cell block in case of adenocarcinoma. Here we see conventional smear of squamous cell carcinoma, cell block of squamous cell carcinoma, and P63 positivity in cell block in case of squamous cell carcinoma. Here we see synaptophysin positivity on cell block under 200x and 400x magnification in case of small cell carcinoma. Now coming to discussion. In our study, 61 to 70 years accounted for the majority of the cases, which contrasted with the Indian study of Bansode et al. The findings of mean age, sex ratio, and smoking habit concorded with the relevant Indian studies. Cell block with IHC provided additional yield of malignancy, which was consistent with the findings of Datto et al. Like Nityananda et al. And Matthew et al., we found high sensitivity, specificity of cell block and IHC in our study. In our study, the rates of positivity of P63, TTF1, and sanitophysin concorded with the study of Tan et al. The most common carcinoma in the study was adenocarcinoma, which was like the findings of Kashyap et al. And Cord et al., but unlike the studies of Singh et al. And Rawat et al., who found it to be squamous cell carcinoma. Now to conclude, cell block preparation is a convenient tool for preliminary diagnosis. It has high sensitivity and specificity. A small panel of immunomarkers consisting of TTF1, P63, and sanitophysin proved to be quite useful in preliminary diagnosis and basic classification of lung cancer. A combined approach of examination of aspirated material to conventional smears, cell block preparation, and subsequent immunohistochemistry for accurate diagnosis, as every own method has their own lacunae. This study reported higher efficiency of cell block method. In a resource limited setting, a panel of antibodies with cell block can be a game changer for more accurate diagnosis. These are some of the references. Thank you.
Thank you so much. So, a very good study, Shubhargo, and the best part of it is you have presented it very well. Flawless presentation. Well done. There are certain queries which I would like to ask you. Number one is, what was the method which you used to prepare cell block?
Sir, we used CT-guided FNSC material. The CT-guided FNSC material was divided into two parts. One was used to prepare conventional smear, and other part was used for preparation of cell block. This material was first centrifuged for 10 minutes at 1500 RPM, and the cell plate thus obtained was used for preparing cell block.
Yeah, I saw your material and methods.
We did not use any other clotting method. The cell plate was allowed to stand, and then we used it for making the cell block.
Yeah, exactly. I mean, you didn't use agar or you didn't use thromboplastin.
No, we used the spontaneous clotting method. We did not.
Yeah, that's right. That's what I saw, that you are basically using a clot, and cell block is very efficient for paucicellular smear, and rinsing the syringe with formalin makes the utility much more. And in that situation, the clot becomes a big issue. The very fact that you have excluded paucicellular smear,
yes, sir,
somehow defeats the purpose of cell block.
Sir, paucicellular material, we used that almost cystic fluid we excluded, and very paucicellular material we excluded, but not the normal less canticellularity material we did not exclude.
Yeah, right. Another thing which I would like to ask you is that something which you really missed out on your presentation was that in the basic introduction, you said that there were 3 observers who observed the findings.
Yes, sir.
There is no reference to the observers, inter-observer variation, or what were their findings and where they were discordant in the entire process, and what you did in trying to, come to a conclusion.
Sir, the 3 different pathologists were performing the 3 different parts of the study. Sir, the histopathology was performed by one pathologist. There was no bias. There was no communication of the diagnosis. The cytology part of conventional smear was performed by a separate pathologist, and the cell block with IHC was done by a separate pathologist. So there was no communication.
That makes things much more difficult.
And then it was compiled later. The data was later compiled together and plotted here.
So you have 96% concordance between 3 pathologies. Very well done. Anyway, I'll ask other of my co-judges to ask questions. Ankita, are the other judges there?
Yes, I am. Yes, I am. Am I audible?
Yes,
hello.
Sir, you're audible.
Yes,
Yes, sir, you're audible.
Okay. Thank you, Dr. Shubhargo. Is it your thesis paper?
Sir, this is my thesis paper, part of my thesis paper.
Okay. You done good work. I have a few question. First of all, you confirmed by histology. Okay.
Yes,
Did
sir.
you go for
Complete
IS?
histology.
Complete histology. Histology along with immunohistochemistry or only
Sir,
histology?
only histopathology, not immunohistochemistry.
You have not done the ISC for
No,
histology?
not for
No.
this study, sir.
Okay. Another area, you in cytology and cell block, you mentioned that the positive for malignancy,
Yes, sir.
suspicious for malignancy,
Yes.
and negative for malignancy. But in cytology and from the cell block, you give the specific diagnosis, specific type of cancer, lung cancer. Give you specific type or just like
Sir,
positive?
that part I performed for my thesis, the specific diagnosis. Here for easy interpretation and getting of sensitivity, specificity, and positive and negative predictive value, we had to take binary dichotomous diagnosis, like positive for malignancy, negative for malignancy. If I did it in much more detail, I could not get the sensitivity and specificity of this study.
Oh, that's why you are mentioning positive for on suspicious like that. Okay. Another I have a question. Is if you face any difficulties like dilution problem during your cell block preparation and smear preparation, as you perform in the same way, in the same setting?
Sir, dilution was a problem, but we did the cell blocks not in the same settings. As the specimens came along, we performed the cell blocks, and then we archived the cell blocks, and then when we brought back from the archives, and we did the histopathological examination of it.
Okay, thank you, Devago.
The last part is not very clear. The last part of the answer was not clear. I mean, were you present when the FNSC was being done, Shubhargo?
Sir, it was a CT guided FNSC, and
were you present there? Were you present there for all the 120 cases?
Sir,
were you present for all the cases?
Sir, not. I was not present for all the FNSCs.
Who was collecting the cell block for you?
Sir, it was sent by. It was the specimen was sent by the Department of Radiology to us, and we used along with the chest medicine department. We got the specimens, and it was labeled, and history of the cases were provided.
You got this. You got the smears, FNA smears, and you got the blood clot.
Yes, sir.
Oh,
it was
that is not okay. I mean, cell block preparation should be done right at the site of the procedure, you know, and ideally you should be using formalin for, you know, rinsing the syringes and collecting it in the formalin straight away. Because clotting artifacts will be too much to handle. I mean, you're virtually using a clot preparation rather than a cell block, true cell block. There is an article I think you must be knowing by the Indian Academy of Cytology, which is a landmark milestone article by multiple authors, which categorically specifies how to handle fluids and cell blocks and has standardized that. And now nationally, everybody is supposed to follow that. So please follow that, right? Otherwise, you presented very well, very crisp. Your knowledge is very good. Thank you. Well done. Ankita, we can go to the next person.
Yes, sir. So our next presenter, Dr. Deep, are you there? Dr. Deep?
Yes, I'm present. Hello.
Okay. So Dr. Deep Banerjee is the second year PGT from North Bengal Medical College. His topic, classification of clinical goitrous nodules FNSE into TBS RTC categories and institutional experience in sub-Himalayan belt of North Bengal. Dr. Deep, you may start your presentation.
Am I audible?
Yeah, you're audible. You're audible, you're visible. You may start.
A very good afternoon to all esteemed judges.
Your slides are not visible.
I have shared my screen. Is it visible now?
Yeah, it's visible now, but can't you do the slide share option? No, it's not visible.
Can someone share it on my behalf?
Mr. Deepak, hello.
Deepa, have you shared the slides to us?
Yeah, I have shared with.
No.
I have shared it in that group I have shared.
No, Deep, we do not have your slides.
Please try sharing it with yourself, Deep, and share it from the slide sharing option. It was there. Just come back to your presentation here.
Now,
upstairs, go on the top and share the slides rather than using the lower platform.
Is it now visible?
Yes.
It's visible, but those ribbons are there on the top and the right hand side.
Whenever I am using the slide share, it's becoming non-visible actually. This part is visible and some issue is happening now. That's why.
You please continue with this. Okay, yeah, we can see. Come on.
Can I? Okay.
Yes, please go ahead.
Thank you, sir. Very good afternoon to all esteemed judges, to my teachers, and to all the seniors and the colleagues present. Today I will be presenting my topic, the classification of clinical goitrous nodules FNAC into TBSRTC categories and institutional experience in sub-Himalayan belt of North Bengal. To introduce this topic, I would like to state that thyroid nodule is a very common presentation in the patients presenting here in the sub-Himalayan belt. The fine needle aspiration cytology or FNAC of thyroid nodules is a rapid, cost-effective, and very useful diagnostic modality. The TBSRTC classifies thyroid FNAC into 6 categories. Each category has been designated risk of malignancy or ROM and has a recommended clinical management for the same. The objective of the study was to analyze clinicopathological spectrum of goitrous lesions as per the TBSRTC protocols and to correlate the cytological findings with the histological reports which were available to us. In the materials and methods, a respective retrospective observational study was conducted at institutional level at Department of Pathology, North Bengal Medical College and Hospital. The time period of the study was from August 2018 to August 2021. Altogether, 330 FNE cases were reported as per the TBSRTC protocol, which were referred from OPD in these 3 years, and out of which 145 cases underwent surgery, and out of these 145 cases, 125 of them later followed with histological reports. FNS or fine needle sampling was done with 22 to 23 gauge needles, and adequate number of passes were taken. FNA or aspiration was done in cases where adequate material was not obtained on FNS or in cystic lesions. Smears were both air dried and fixed in alcohol and stained by Leishman stain, hematoxylin and niacin stain, and papillomavirus stain. All slides were interpreted by experienced cytopathologists in the Department of Pathology and reported as per the TBSRTC protocol. The cytopathological records, including the patient details, were reviewed and slides recovered from the archives. The records of the slides of the histopathological assessments were also reviewed. The inclusion criteria that we have followed in this study is all the cytologically diagnosed cases which followed up with histological reports after surgery, and the exclusion criteria was the cases which could not follow up due to the unavailability of the histopathological reports or the cases which were lost to follow up. As I have already discussed, 330 FNA cases were taken, out of which 145 underwent surgery and 125 of them followed up with histopathological reports. The detailed tabulation of these 125 cases have been discussed later in a slide. This is the 2017 revised Bethesda system of reporting of thyroid cytopathology, wherein the category 1 is non-diagnostic or unsatisfactory, category 2 is benign, category 3 is atypia of undetermined significance or follicular lesion of undetermined significance, category 4 is follicular neoplasm or suspicious of follicular neoplasm, category 5 is suspicious for malignancy, and the category 6 is malignant. And the risk of malignancy equated with NIFTP have been showed in this table, and the usual management has also been discussed. Some of the pictures, the figure 1, here we can see atypia of undetermined significance, which has been denoted category 3. The figure 2 is of Graves' disease, which has been denoted category 2. The figure 3 is of Leishman stained smear of suspicious for follicular neoplasm, category 4. The figure 4 is of non-Hodgkin's lymphoma, which has been designated category 5. The figure 5 is of papillary carcinoma of thyroid, which has been denoted category 6. The figure 6 is of medullary carcinoma of thyroid, which has been denoted category 5. In the results and analysis, the mean age that was noted in the study was 40 plus minus 15 years. The male female ratio of 1:4. The histopathological correlations with previous cytological findings was done in 125 cases, as I have explained before. For Bethesda category 5 and 6, 90.90% and 100% incidence or the risk of malignancy was found respectively. In Bethesda category 1, 1 out of 10 cases turned out to be malignant on final histopathological diagnosis, corresponding to a risk of malignancy of 10%. In category 2, it was 2 out of 70 cases, a risk of malignancy of 2.85%. The category 3 and the 4 had an incidence of malignancy of 23.52 and 42.85% respectively. The sensitivity, specificity, positive predictive value, and the negative predictive value were calculated for the categories 1, 2, 5, and 6. The categories 3 and the 4 were left out in this, as they were the indeterminate categories in which malignant and benign cases could not be delineated well. Out of the 4 categories, we calculated 78 cases which were malignant and 23 cases which were found to be benign on final histological diagnosis. We obtained a sensitivity of 98.71%, a specificity of 86.95%, a positive predictive value of 96.25%, and a negative predictive value of 95.23%. In the indeterminate category, that is the category 3 and 4, the risk of malignancy was 23.52 and 42.85% respectively. Here is the tabulation that I have explained, the category-wise division of FNA cases, their final histopathological diagnosis, and the corresponding risk of malignancies. The first pie chart here is the division of
1 minute is left.
125 cases into their different categories. The second is the division of the histological diagnosis into benign and malignant. Here are the pie charts which divides histopathological diagnosis into individual categories. The sensitivity specificity calculation I have shown here, and as I have already discussed, the sensitivity was 98.71%, specificity of 80.95%, positive predictive value of 96.25%, and a negative predictive value of 95.23%. To conclude our study, I would like to say that the Bethesda system of reporting of thyroid cytopathology is effective. As per the results, the sensitivity, specificity, positive predictive value, and the negative predictive value was on the higher side when matched to national and international studies. The incidence or the risk of malignancy was concordant with other studies, which proved FNAC as a tool in initial diagnosis of thyroid is effective. The category 3 and the 4 were indeterminate and were left out during the calculation of the above indices, but the risk of malignancy of these categories were calculated. The major downside of this study was the lack of cases or a reduced number of cases due to the COVID-19 pandemic and the cases which were lost during follow-up. Thank you.
Thank you.
Thank you, Deep.
Thank you, sir.
Dr. Anjan, please
Yes.
go ahead.
Deep, you've done a vast study. what are the problem you faced during the categorization of the thyroid lesion?
Sir, the delineation of the benign and the malignant cases in the categories 3 and category 4 were a difficulty that I have faced during this study. Another difficulty that was majorly faced was the loss of cases due to follow-up, sir, and maybe due to the ongoing pandemic, sir.
Okay. And another, you taken only the clinical cases, no? You did not take any subclinical or microscopic micronodular lesion of the thyroid, micronodular thyroid lesion.
Sir, as this is a retrospective study, I have gone in the registers and checked the year, so I have excluded those cases, sir.
Yes. Okay, thank you, Deep. Sir.
Thank you, sir.
Yeah,
Nadim sir, please.
Good afternoon,
sir. Thank you, Dr. Deep.
Thank you, sir.
Few comments. Please don't take me if I'm harsh. Number one is, why did you do this study? What is new in this?
New.
Sir, this study has been done a number of times, but sir, as I couldn't find any other topic in the designated time, so sir, I came up with this one.
So, okay, fine. That's very honest. Yeah, because to tell you the truth, as an award paper, a retrospective study, primarily purely compilation and statistics, doesn't hold too much of depth, number one. Anyway, don't get disheartened by that. Second thing is, the second thing which I would like to know is that did you get access to the slides? Did you see the slides, or you only saw the reports and compiled them?
Sir, not all the slides, as the archive of 3 years archive is not much available, sir. I came across a few slides of all the 3 years, but I majorly dependent on the final diagnosis, histological diagnosis that were available.
Okay, yeah, because I thought if you could put in your input and disagree with what your pathologists have reported earlier, particularly category 3, category 4. And the third part, which I would like to know, is if you can just show me your conclusion again.
Yes, sir, sure, sir.
And yes, come to that second point. Yeah, this one. Yeah.
Yes,
so
sir.
this,
As
you
per the,
are getting a
yes,
higher sensitivity, higher specificity compared to the national and international data.
Yes, sir.
And in some cases, the sensitivity and specificity is pretty high, quite high.
Yes, sir. Sir,
so how
maybe
do you?
Yes, sir.
Yeah, go ahead, please go ahead.
Sir, maybe due to the which during the calculation, sir, which the problem that I encountered is that, sir, in the national and the international studies which I have referred to for this case, sir, there were 600 cases approximately, 500, 600 cases, sir. There were plenty of cases, sir. I have done with a comparatively lesser number of cases. That's why maybe the statistics turned out
are
to be...
are the number of cases which you have chosen, are these sequential cases, or you have chosen by a particular personal bias?
No, sir. I have chosen sequentially, sir.
All sequential cases.
Yes, sir.
Okay, fair enough. Thank you so much.
Thank you, sir.
Thank you.
My pleasure. Thank you, sir.
Yeah, thank you, Ankita. I think we are done.
Okay, sir. So Dr. Subarga and Dr. Deep, thank you for your wonderful presentations. And I thank all our respected judges for your valuable time and thoughts. So we have come to an end for a... Yes, Arjun, sir. Yeah.
Okay.
Thank you, sir. Thank you so much. So we move on to our third session, that is award paper in microbiology. I'll introduce our judges, Dr. Shankar Sengupta, sir, and Dr. Bhaskar Narayan Chaudhary, sir. Dr. Shankar Sengupta, sir, is the medical superintendent and head of Department of Lab Services, CNCI, Kolkata, and specialty board member microbiology, NBE, DNB, India. And Dr. Bhaskar Narayan Chaudhary, sir is the Chief Microbiologist and Senior Consultant, Department of Microbiology and Molecular Biology, and Infection Control Officer, Peerless Hospitals Hospital and Research Center Limited, Kolkata. So I have explained the rules for presentation. The same is here for the microbiology also. Total 10 minutes, reminder at 6 minutes plus 1, and the question answer session will be for 3 minutes. Dr. Debopriyo, are you there?
Yes, I am.
You're there. Okay. Dr. Debopriyo is third year junior resident of Nirratan Sarkar Medical College, Kolkata. The topic is COVID-19 associated mucormycosis, a detailed case series from a tertiary care center in Eastern India. Dr. Debopriyo, you may start your presentation.
Yes, is my screen visible?
No, you're audible and you're visible, but your screen is not visible.
Okay, how about now?
Yeah.
Now it is visible.
Yes, thank you. So,
you may start. Yeah.
Very good afternoon to all the respected judges and my fellow audience. My study is entitled COVID-19 associated mucormycosis, detailed case series from a tertiary case center in Eastern India. As we all know, coronavirus disease 2019 is associated with a plethora of different kinds of co-infections ranging from bacterial, fungal, and viral. Rhino-orbital mucormycosis, that is colloquially and erroneously called black fungus in our COVID-19 era, it is a rare but deadly angioinvasive fungal infection that has shown a quite explosive trend in the setting of COVID-19. Positive organisms belong to the order Mucorales, phylum Glomerulomycotina, that include the genera Rhizopus, Mucor, Rhizomucor, Canigamella, Lichthymia, and others. Rhizopus arisis is the most common culprit in rhino-orbital mucormycosis associated with COVID-19. Diabetes mellitus is found to be the main underlying risk factor in an Indian scenario for this disease. Aims and objectives of this study is to promptly diagnose mucormycosis using histopathological and microbiological examination and to guide the clinicians for proper management. It is a case series done in the Department of Pathology in collaboration with the Department of ENT and Microbiology in NRS Medical College. Sample size of 20. The study period is from May 21 to July 20. As you can see within the results, the majority of the patients are male with an commonest age distribution of 40 to 70 years of age. Main risk factors that were presented, chief among them was hyperglycemia presentation, while 3 patients presented also with malignancy. And there was 1 patient who was on corticosteroid therapy for nephrotic syndrome. Among the hyperglycemic patients, as we can see, the chief was type 2 diabetes. Coming to the treatment that they received for COVID-19, majority of the patients, 85% actually, received steroids, 20% received tocilizumab, and 10% received remdesivir. Within the steroids, dexamethasone ranked the highest among the cases of mucormycosis, amounting to 53%. On the clinical features, the main presenting features were nasal blockage along with headache and unilateral facial swelling. 40% patients also presented with palate necrosis and 10% presented with unilateral vision loss. Location of mucormycosis was chiefly rhino-orbital in location, along with 35% having nasal and sinus involvement only, and 35% cases presented with histopathologically confirmed bony involvement. And 1 patient presented with pulmonary mucormycosis. Coming to the treatment followed after the diagnosis, 60% of the patients received amphotericin B, while other 40% also received aggressive surgical interventions for it. The outcome, 60% patients recovered, while 25% succumbed to the disease. 10% patients were unchanged at the time of making this study, while 1 patient was lost to follow-up. Here are the pictures. Figure 1 and 2 shows the maxillary sinusitis, which was later on proved to be mucormycosis. Figure 3 shows the orbital involvement, And figure 4 shows the patient with bilateral mucormycosis, showing bilateral pulmonary mucormycosis. And coming to the gross pictures, figure 5 and 6 shows the gross appearance of the surgical specimens that were sent to us. Figure 5 and 6, you can see the black eschar over here. This patient actually also underwent right eye enucleation along with maxillectomy. Coming to the next pictures, this is a section to the eyeball of that patient I showed earlier. This is the eyeball, this is the sclera. This mass of necrotic tissue on high bore examination showed this hyphae, fungal hyphae, broad aseptate, branching at right angles and optics angle. This is an illustration of the fungi chiefly embedded in the necrotic tissue. You can see the broad aseptate fungi. This is a picture wherein a blood vessel is seen to be invaded by the fungi. This is the endothelial lining actually, and these are the fungal elements. This shows the bony involvement. Here the bony fragment is seen, which is chewed through by the fungi as displayed over here. These are the hyphae. This is a picture of a past stain done for the one of the earlier cases. Here are the past positive fungi.
আবার গন্ডগোল শোনা যাচ্ছে না শোনা যাচ্ছে না
Mr. Dr. Das, so you're muted.
Dr. Debupriyo, unmute. Yeah, you're not.
And share your screen. If your net is slow or lagging, then please stop your video and continue and share your PPT and speak.
Okay.
Video take.
Now?
No. Share the PPT.
You share your PPT only. Do not just close your video. In the Zoom Connect, close your video. So you will not be, yes. Now you try to show the slide.
Okay.
Share screen.
Are you able to see the slide now?
No. You just minimize the slide which you are seeing is not presentable here, but it is on full mode. I can understand.
Please start slide sharing.
Slide sharing. Yes.
Now it's visible.
Now it's visible, right? Okay. So I'm continuing. These are the pictures from the microbiology laboratory actually. Yeah. This shows the KOH count, and figure 14 here. This shows the growth on SDMEDA of rhizopus, and this is a lactophenol cotton blue mount that is showing the nodal rhizoids over here and the sporangium over here. Coming to the discussion, mucormycosis is the third most common invasive fungal infection with a very high morbidity and mortality. Particularly prevalent in India among the diabetic patients who have poor glycemic control, in contrast to the developed nations where it is mostly seen in association with hematological malignancies or transplant recipients. Demonstration of broad aseptate and sparsely septate fungal hyphae that show branching at obtuse or right angle admixed in a necro-inflammatory or a hemorrhagic background that is mainly dominated by neutrophil infiltration. This comprises the most direct and convincing proof of mucorales infection. Microbiological identification from done by a culture will also give a stamp on the diagnosis and also helps in the species identification. Okay, so coming to the factors that contribute to this disease, poor glycemic control and diabetic ketoacidosis are often worsened with corticosteroid therapy. Low pH that is seen in the respiratory acidosis due to hypoxia in COVID pneumonia or a metabolic acidosis due to diabetic ketoacidosis both creates a fertile media for the growth of mucor. Free iron, this is also a very important contributing factor. A prolonged hyperglycemia will cause glycosylation of the ferritin and transferrin, thereby making free iron more available to the fungi, and iron binding capacity is also reduced. The fungi will utilize that iron. High level of interleukin 6 and acidosis also contributes to intracellular ferritin levels. Lastly, GRP78 is a heat shock protein that is acting as a chaperone in the endoplasmic reticulum. It is also expressed on the cell surface as a marker of ER stress. Now, mucormycosis spore coat protein homologs COTH2 and COTH3 act as ligands to this GRP78. Thereby, they can easily bind to the nasal epithelium cells and thereby gain entry into the tissue. On conclusion, in an Indian context, COVID-19 associated mucormycosis seems to be the result of a complex interplay between diabetes, widespread and in some cases overzealous use of corticosteroids, and complications of COVID-19 infection itself. A thorough history taking, a proper clinical history taking, including the treatment details, and also using parallel stains like PAS and methenamine silver will help in making a prompt histological diagnosis. Also, evidence of angioinvasion and bony invasion are very ominous signs that must be included in the report if found. So, a prompt diagnosis followed by an aggressive surgical debridement and liposomal amphotericin B or prosaconazole-based therapy will help in save the patient. A little delay can really prove costly as this disease spreads very fast. It is highly invasive, prefers the blood vessels, and so can kill the patient within 12 hours if left untreated. Lastly, adherence to strict guidelines regarding the use of corticosteroids and a very strict glycemic control will also help in prevention of this disease. So my references. Thank you, everyone.
Thank you,
Thank you.
Just I would like to have two questions. And before telling you something which I think you will take it in positive mind. I mean, in future when you will present somewhere in a virtual conference, please do not swing yourself, because that gives a very bad vibes to the judges as well as the audiences. So that is number one. Number two is I just would like to ask you, you had worked in conjunction with your pathology department as well as the clinical department of all the cases you have suggested or put in your paper, or you just restricted yourself in the microbiology lab?
Sir, I am a pathology PGT.
Okay, you are a pathology PGT. Okay,
yes.
Fine. Okay. So then I would like to know from you details. That is, how many of these cases were from rhino orbital movement, how many of them were rhinocerebral involvement, and how many of these cases had the paranasal sinus involvement?
Sir, can I go back to the slides?
Yeah, yeah.
Okay. So, yeah.
Okay, it was very small, that's why I couldn't find. Yes.
So 40% were rhino orbital. 20% of the cases had definite CNS involvement, while 35% had histologically proven bone involvement, and in 35% cases the disease was restricted to nasal and sinus only.
So the maximum number was rhino orbital. Okay. Yes. It is a very similar to a case. I mean the case presentation, or rather the you can say another presentation which has come up in the international paper by one Indian National Institute. Do you know about that? I mean, the similar kind of thing. That is, rhino orbital is coming the most, and then followed by rhino cerebral, and then followed by paranasal sinus. Because yes, your topic is absolutely the same topic which they worked on and they had in that presentation. Do you know about that?
Yes, it is probably by Singh et al. Probably.
Yes. Singh et al. From All India Institute of Medical Science.
Yes, I read that.
You have read that. Okay, fine. That is number one. Number two is that my question is that in international papers and or even in the media, there were reports that Indian patients are having the black fungus, which are I mean miming the COVID disease. Actually, it is not COVID. For some other reasons also they are having this. So do you believe that? If so, what could be the other reasons of patients who are miming COVID disease but finally diagnosed as a black fungus? You got my question? I mean that is in international media.
Yes.
Mucormycosis, the black fungus, they were telling miming COVID patients in India. Miming. It is not actually COVID. COVID is coming negative, but black fungus is coming. BBC reported it at several places. So I just want to know, do you agree with that? If so, what were the other reasons in India, particularly during the COVID time, it created this kind of scenario?
Other diseases, sir, malignancy patients may also have COVID-19 because also have mucormycosis because of the same reasons. There is neutropenia and acidosis and all. Transplant recipients may also present because these factors also present with a very fertile ground for mucormycosis. So patients may present, and simply before even the advent of COVID-19, an uncontrolled diabetes mellitus patient had a well-known complication of rhino-orbital mucormycosis that sometimes—
That you have already told. Actually, there is a practical problem. See, one is that during the COVID time, it has been seen that Indian population having a high hyperglycemic index.
Yes.
Because of the condition that you are at home, you are not being allowed to go outside.
Yes, exactly.
People are eating more, something like that. That was something already presented. And second was that people started taking a lot of precautions to avoid COVID, including hot fermentation and hot nasal every day almost. And that created the actually problem of that. Anyway, otherwise your presentation was quite good. And steroids, yes. Rampant use of steroids. Steroid inhaler. Yes. So I think I will now, it's over for me, and Dr. Bhaskar is there to ask.
Okay, so thank you, Dr. Devapriya, for choosing a very pertinent and important topic. So out of these 20 patients, how many of them were COVID positive? I think you told it, but I missed it somehow.
Yeah, they were. I mean, I will show you this. Yeah, 60%.
You don't have to show, just 50%.
60% of them had active COVID infection, while 40% actually had COVID infection within the last 20 days.
Okay, so all of your patients are only from COVID. You didn't take any non-COVID patients into.
We didn't get one.
Okay. And how did you diagnose? All of them were diagnosed histopathologically, or did you have PCR also, mucor PCR and microbiology?
No, we don't have PCR. This was all done histopathologically, and some of them
microbiology culture.
Yeah,
culture. How many of them were culture positive?
12 patients were culture positive out of these 20.
Okay. Was a KOH mount also done?
Yes, KOH mounts were done. I think I gave a picture of a KOH mount.
Yes, you have shown.
What was the positivity by KOH?
Sir, I didn't do an exact analysis. But they thought about half of them showed positive in KOH mounts, I think.
No, it should be more than that. No, it should be more than that.
I may be wrong, sir. I did not do a statistics on that.
Did you go to the microbiology department, by the way?
Yes, I did.
Coordinate.
And another thing, did you study the ferritin level of these patients? Because this mucor has a very propensity for the metal moieties like iron and zinc. Another thing that Dr. Arunala Chakraborty also pointed out, that most of the COVID patients were receiving zinc formulations, which also increased their
propensity
incidence of this mucormycosis. So, did you study the ferritin level and zinc?
No, sir, I didn't study them separately. I mean, I didn't order ferritin to be done.
Okay.
But most of the patients had already a ferritin level done as a part of the inflammatory panel along with CRP.
Yes.
So many of them were high.
So if you can carry on the study and you can see how many patients were also receiving zinc. You have done the hyperglycemia and those things. So it will be a very important and study. So thank you very much.
Thank you.
Thank you, sir.
Thank you.
So I think Ankita, over to you.
Ankita, over to you.
Yeah, thank you, Dr. Devapriya, for your wonderful presentation, and all our respected judges for your valuable time. Thank you so much. So we have come to an end to the award papers. Now move on to our next session, that is the free paper presentation. I'll invite our chairperson, Dr. Jayati Chakrabarti ma'am. She is the
Hello.
professor of Hello.
Hi, am I audible, Ankita?
Yeah, ma'am.
Thank
Ma'am,
you.
you're audible. Ma'am, you're audible. Dr. Jayati Chakrabarti ma'am is the professor of pathology and dean of ESI PGI MSR Maniktala, Kolkata, and she is a life member of IAPM. Ma'am, over to you.
Thank you, Dr. Ankita. Wish you all a very good afternoon. So at the outset, I wish to express my gratitude to Amita Giri madam and her team for giving me this opportunity. I am extremely honored. So before we proceed, I would again request all the speakers to complete their presentations within the stipulated time. I would say that an extended time for presentation may not be permitted. Now, there is another issue in this particular session, like all the delegates are invited to post their questions in the chat box for the discussion. So this is a little deviation from the previous sessions. So again, I would request all the delegates to keep their mic muted if not speaking, otherwise it disturbs the speaker. Thank you very much. Over to Dr. Ankita, please.
Thank you, ma'am. Jayati ma'am has all explained the rules properly, so everything is clear. So Dr. Aditi, are you there? Dr. Aditi? Hello? Hello?
Just a second. Yeah, I'm there. Please, just a second. Huh?
Okay.
Dr. Ankita, Dr. Ankita, just repeat the timings, okay? The time for discussion. That's all.
Okay, ma'am. I'll repeat it. So the total presentation will be for 8 minutes. And the reminder will be given at 6 minutes, 6+1. And the question answer session will be for 1 minute. So according to the time available, we'll take up the questions from the delegates. So Dr. Aditi?
Yeah. Please, just a second. There's some problem with my presentation. Just a second, please. I'm there only.
Okay, fine.
Yeah, just give me 2 seconds.
Okay, sure. Dr. Aditi Mittal is from Pravara Institute of Medical Sciences. Her topic is Histomorphological Spectrum of Lateral Neck Swellings, a retrospective institutional study.
It's opening, just a second. Huh?
Yeah. Dr. Aditi? Hello? Dr. Aditi? Hello?
Hello, am I audible?
Yeah, you're audible, but you're not visible and your slides are not all.
Yeah,
Hello?
I'm just doing it. Just a second. Can you see my slide?
Yeah, it's visible now. Yeah. Please keep on your video while presenting. Okay?
Yeah, just a second. Yeah.
Yeah, sure.
Is my video coming?
Yeah, it's under the name of Shefali.
Yeah. I just
fine.
have to edit it.
Okay, fine. You may start your presentation.
Okay. Good afternoon, judges. My today's topic is Histomorphological Spectrum of Lateral Neck Swellings. It is a retrospective institutional study. Introduction. Neck swellings form a significant cause of mortality and morbidity in India. These can be divided into midline or lateral neck swellings. The lateral neck region includes the area of posterior triangle, carotid triangle, and submandibular triangle. Spectrum of lesions varies from congenital disorders, inflammatory lesions, benign, as well as malignant lesions. Malignant lesions can be both primary and secondary, and they are more common in adults as compared to the pediatric population. The common causes for the swellings include lymph node swellings, thyroid swelling, salivary gland enlargement, and bronchial cyst. Materials and methods. We have conducted a retrospective observational cross-sectional study of total 148 cases of lateral neck swellings, which were retrieved from the archives of the Department of Pathology, Rural Medical College, Pravra Institute of Medical Sciences, over 2 years of duration from January 2018 to December 2019. Inclusion criteria: all lateral neck swellings received in the Department of Pathology during the study period. Exclusion criteria: cases with midline neck swellings, midline swellings with lateral extensions, lateral neck swelling cases for which H&E slides or the FFP blocks were not available, and the histological diagnosis of swellings was reconfirmed. Result: the study included total 148 cases, out of which 69 were males and 79 were females, with the male to female ratio of 0.8:1. The right-sided lesions were 55% and they were more common than the left-sided lesions that were 44.6%. Age range varied from 3 to 84 years with the mean age of 34 years. Most common age group involved was 30 to 39 years. The malignant neoplasm of the lymph nodes was seen in 41, that is 27% cases. Benign neoplasm were in 13, that is 8% of the cases, and non-neoplastic conditions were in 94, 63.5% of the cases. The overall lymph node lesions were common, followed by thyroid, 37%, salivary gland, 13.5%, and others, 11.4% respectively. So this is a pie chart and a diagram depicting the number of cases were maximum for the thyroid, 47, that constitute 31.7% of the cases. Then malignant neoplasm, there were 41 cases, constituting 27.7% cases. Reactive lymphadenitis, there were 14 cases, constituting 9.4%. Benign neoplasm, there were total 13 cases, constituting 8.7%. Granulomatous lymphadenitis, there were 11 cases, constituting 7%. Benign cysts, there were 11 cases, again 7.4%. The others cases were 9, constituting 6% of the cases. And sialadenitis, there were 2 cases, approximately there were 1.3%. Now this is a age-wise distribution of the various lesions which were seen. This is, among the reactive lymphadenitis, there were total 14 cases and they were maximum seen in the age group of 0 to 9 years. Then granulomatous lymphadenitis, there were total 11 cases and the maximum was seen during the 40 to 49 years of age group. Then malignant neoplasms, there were total 41 cases and the maximum was seen in the 50 to 59 years of age group. Thyroid non-neoplastic conditions, there were total 47 cases and the maximum was seen during the 30 to 39 years of age group. Benign neoplasm, there were total 13 cases and they were seen during the different age groups like 20 to 29 years, 30 to 39 years, 50 to 59 years, and 70 to 79 years. Then sialadenitis, there were only 2 cases, which was seen during 50 to 80 years of age. Then benign cysts, there were total 11 cases and the maximum was seen during 0 to 9 years of age group. And other cases were total 9 and they were maximum during 30 to 60 years of age group. So these are the table which shows the type of malignancy which we got. There were lymphoma that constitute 12 cases, that is 29%. Squamous cell carcinoma constituting 5 number of cases and 12.1%. Mucoepidermoid carcinoma, there were total 5 cases constituting 12.1%. Metastasis, there were 6 cases constituting 40.6%. Papillary carcinoma thyroid, there were 3 cases and they have 7.3%. Adenoid cystic carcinoma, there was only just single case constituting 2.4%. Poorly differentiated carcinoma, there were total 8 cases and it constituted 19.5%. And ethnic cell carcinoma, there was only single case constituting 2.4%. So these are the malignancies, total 41 malignancies which we got. These are the representative images. First, the branchial cyst, that is a 40x, then lymphoma, tuberculosis lymph node, mucoepidermoid carcinoma, then multinodular goiter, and squamous cell carcinoma. Discussion. Raj Bhandari et al. Found that the highest number of cases included lymph nodes, that is 29, followed by thyroid 24 and salivary glands 10, and 1 case which was a soft tissue swelling over the occipital region, which is consistent with the present study. A study conducted by Das et al. Reported that approximately 47.5% of the affected patients had infective or inflammatory lymphadenopathy, followed by tubercular lymphadenopathy, metastatic nodes, and lymphoma, consistent with the present study. Goiter, which is the most common non-neoplastic thyroid lesion, was the commonest lateral neck mass lesion as compared to the Manjula et al., where reactive lymphadenitis was the commonest lesion. The most common lateral neck swelling seen in children and adolescents were enlarged lymph nodes, comparable with the results of Manjula et al. Tuberculous lymphadenitis accounted for 7.4% as compared to the 16.84% by Manjula et al. And 24% by Tabassum et al. Malignant neoplasms were the commonest cause of lymph nodes in patients older than 40 years, and similar findings were noted by Asman et al. And Manjula et al. Goiter was the commonest non-neoplastic thyroid lesions comparable with the studies conducted by Manjula and Tabassum et al. Benign neoplasm of the lateral neck swellings accounted for 8.7% as compared to 6.5% by Manjula et al., the commonest being the pleomorphic adenoma in the salivary gland. Benign cystic lesions were found in 7.4% of the cases. And in our study, the most common tumor metastasizing to the neck nodes was squamous cell carcinoma, which was consistent with other studies. Conclusion, the lymph nodes are the commonest lateral neck masses, followed by thyroid and salivary gland. The most common cause for pediatric and adolescent was lymph node swelling due to reactive or tuberculous lymphadenitis. The commonest primary was non-Hodgkin's lymphoma, followed by metastasis. Reactive and tuberculous lymphadenitis was commoner in younger age group, and among the thyroid, goiter was common, and among the salivary lesions, pleomorphic adenoma was commonest lesion, followed by malignancy. And malignant neck lesions common above age group of 40 years were metastasis, while in pediatric age group was non-Hodgkin's lymphoma. Thank you. These are my references.
Okay, Dr. Ankita, do we have any questions in the chat box?
No, ma'am, no questions.
Okay, so Dr. Aditi.
Yes, ma'am.
Okay, so you presented within the time. Now I have some queries regarding your cases.
Yes,
like these were purely histopathological evaluation of these cases, isn't it? This is not,
yes,
you didn't correlate with the previous FNAs or anything. So it's only histopathology. Okay,
yes,
so now regarding, did you perform any ancillary studies where you are diagnosing the lymphomas or carcinomas or squamous cell carcinomas?
No, ma'am. We just evaluated the number of cases and the age-wise distribution of the various cases for the lateral neck masses.
Okay, so when you're classifying your granulomatous lesions or lymphomas for that matter, faced any difficulties for the diagnostic purposes? Like you are putting them in a particular category, isn't it? So
yes, ma'am.
What is the difficulty you faced and how did you sort out those? Any one or two cases?
Actually, ma'am, we got very less cases of the lymphomas and tuberculous lymphadenitis, like frankly speaking. So the cases were very less. And in tuberculous cases, like we easily get the granulomas, so it wasn't that difficult to like differentiate them.
How did you confirm it to be a tuberculous granuloma? Like, did you do any other stains, special stains or a microbiology?
We did the ZN stain. Like,
and they came out to be positive?
Yes, ma'am. The AFB bacilli was positive. We did the ZN
in all cases.
Yes,
in all the cases. Okay.
Yes,
and what about malignancies? What about malignancies? Any IHCs were performed or lymphomas you performed any IHCs?
Just on the basis of morphology, the diagnosis was made.
Okay. Okay. So I think the time is over, Dr. Aditi, for discussion.
Yes, ma'am. Yes,
okay. I think if you add on of it, some ancillary procedures also, your diagnosis, maybe it will be more confident diagnosis.
Yes, ma'am.
Okay.
Yes,
okay.
ma'am.
Thank you very much for your presentation.
Thank you, ma'am.
Ma'am, okay. So thank you, Dr. Aditi. Now we move on to our next presenter. Dr. Ananna, are you there? Dr. Ananna, are you there?
Yes.
You're there. Okay. Dr. Ananna Khan Das, she is a PGT in NRS Medical College. So her topic is study of immunohistochemical expression of CD55 and CD59 in colorectal carcinoma and their correlation with grade and stage of tumor. Dr. Ananna, you may start your presentation.
Yes.
Yeah. Yeah, you may start.
Okay. Good evening to everyone. My topic is study of immunohistochemical expression of CD55 and CD59 in colorectal carcinoma and their correlation with grade and the stage.
Colorectal cancer is one of the most frequent cancer in the world, and it is one of the leading cause of morbidity and mortality worldwide. And the main cause of mortality is associated with the cancer is tumor invasion and the metastasis. CD55 and CD59 are membrane-bound complement regulatory proteins. These regulatory proteins prevents the uncontrolled activation of the complement and autologous immune reaction, thus protect the normal tissue. Various study report says that the upregulate or aberrant expression of these proteins in tumor cells may help tumor cells to escape from the complement-mediated lysis. And it is also seen that exogenous inhibition of these proteins by specific antibodies or small interfering RNA can sensitize tumor cells to complement-mediated attack. So, targeting these CRPs by using monoclonal antibodies to treat the patient of tumor is very important. Objective of the study is the histopathological examination, including diagnosis of colorectal case, is type, grade, and stage, to evaluate expression of CD55 and CD59 in the diagnosed case of colorectal carcinoma, and to correlate the expression of CD55 and CD59 with stage and grade of the tumor. It is an observational descriptive construction study done at NSM stage from February 2020 to July 2021. Inclusion criteria: all cases of histologically proven colorectal carcinoma obtained by hemicolectomy and total colectomy, benign and non-neoplastic lesion of the colon and malignant lesion not arising in the colon are the exclusion criteria. Sample size is 90. Expression of CD55 and CD59 will be observed at membrane and cytoplasm. The immunoreactivity scoring was the fraction of positively stained cell 5% or less equals to 0.6 to 25% cell equals to 1.26 to 50% equals to 2 points, and 51 to 75% is 3 points, and greater than 75% equals to 4 points. For intensity staining, no stain equals to 0 point, mild or mid or buff stain is 1 point, and moderate or yellow stain is 2 points, and strong stain equals to 3 points. A and B to be multiplied together for the final score, and this is stratified as weak score ranges 0 to 4 or strong score that is ranges 5 to 12. The observation and my results are that is the mean distribution of age is the 52 years, minimum age is 16 years, and maximum age is 79 years. 62% patient is 62% is patient is male patient, and 38% patient is the female patient. The most patient, that is the nearly 49% patient present with bleeding per rectum, and 31% patient present with plain abdomen, and rest is with altered bowel habits. The 10% case present with the positive family history. 86% patient are non-vegetarian. The most common lesion is the site of the lesion is the rectum, 34%, followed by the cecum, that is 30%. The frequency, that is the type of the carcinoma, is the 85.6% is adenocarcinoma, followed by mucinous adenocarcinoma, that is 13%, and significant carcinoma is 1%. Most common histopathological grades, that is moderately differentiated, is grade 2 is 66%, and poorly, then followed by poorly differentiated case, that is 20%, and the well differentiated, that is grade 1, is 14%. Most common stage, AGCC stage, is stage 3, 49%, followed by stage 2, that is 40%. That is the main results here. There is the expression of CD55 in different histopathological grades of the colorectal carcinoma shows that there is the positive correlation between CD55 and histopathological grade. That is the Spearman's correlation coefficient is less than 0.01, and Kendall's tau B correlation is less than 0.001. But in the classification of AGCC stages, the colorectal of carcinoma, there is a non-significant or weak positive correlation between these, because there is the p-value is here 0.129, and p-value for the Spearman's classification is 0.150. In case of expression of CD59 in the different stages, AGCC stages of colorectal carcinoma, there is a significant weak positive correlation between CD59 and the AGCC stages. Spearman's correlation coefficient is equal to 0.007, and Kendall's tau P correlation coefficient is 0.005. That is significant. Then expression of CD59 in different histopathological grades of colorectal carcinoma. Here it is also significantly moderate positive correlation between CD59 and histopathological grade. And the Spearman's correlation coefficient here is less than 0.001, and the Kendall tau B correlation is also significant, that is less than 0.001. But expression of CD55 is a non-significant with negative correlation between CD55 and the age group of the patient. There is also non-significant with negative correlation between CD55 and different site of the lesion. And there is non-significant with negative correlation between CD55 and different types of the lesion. But in case of CD59, we also see the same result, that is there is a non-significant with negative correlation between CD59 and age group, and there is non-significant with negative correlation between CD59 and the site of the lesion, and there is a non-significant with negative correlation between CD59 and type of colorectal carcinoma. This is the CD55 expression, moderately differentiated stage 3 in 408. CD55 expression is mucinous adenocarcinoma in 408. And this is the moderately differentiated CD59 expression, moderately differentiated stage 3 adenocarcinoma, and this is for the poorly differentiated stage 3 adenocarcinoma. What is our findings? That is the expression of CD55 and CD59 are not correlated with the age of the patient tumor site and the histological type. Stronger staining of CD55 and CD59
1 minute left.
in moderately and poorly differentiated colon cancer, and higher stage 3-4 colorectal cancer exhibits stronger expression of CD59 than lower stage. This is concordant with the study by Shang Yu Long and China and Hu Ying et al. Although higher stage colorectal cancer shows the strong expression of CD55, but statistical correlation cannot be established. It corroborates with study by Thornton et al. The conclusion is that in this study, we have tried to reveal the expression of CD55 and CD59 appears to be significant predictors of severity of the colorectal cancer, and this may help in initiating early treatment with targeted therapy. These are my references. And thank you.
Is it open for discussion?
Yes.
Yeah. What is the role of CD55 and CD59 in the cell cycle?
These are they are the cell membrane bounding protein. They inhibit the C3 to C3A convertase to C3 to C3A convertase and C5B to C5A. That is when the complement is acting the cell membrane attack complex. That is the cell membrane is not they inhibit the.
Do you think that actually the cell membrane stimulation occurs by the help of the either by the tyrosine kinase mechanism or one sort of kinase mechanism, whatever, MAP kinase, tyrosine kinase, whatever it may be? Now, do you think that these are the product, this product stimulates the tyrosine kinase or MAP kinase or JAK kinase, whatever it may be? Then why you have done this study?
So may I interrupt, please, sir? Sir, 1 minute. Yeah. So actually, I think it is something to do with the complement regulation. I think she can explain.
Okay. Do you think that there is any correlation with the complement in the development of the cancer or the prognosis of the cancer?
Yes, for the development of the cancer, it is not the complement regulation. That is the
then why you have done the study?
What is the role is that when the cancerous cells attack the immunity system, the complement destroys the complement destroys.
Complement destroys what?
Destroys the cancerous cells.
Is it complement destroy cancerous cells? Is it fact? Or the T cell destroy the cancer cells?
T cell destroys the cancerous cells.
T cells, T cells. So do you think that the CD55 and CD59 stimulates the cancer T cells?
No, they does not directly.
Then what is the correlation? Why did you do this study? What is the objective?
Sir,
just using any marker and see the correlation.
Yes, no, sir.
Excuse me, sir. Excuse me, sir. I think we will have to stop the discussion here because of time constraints. But it is, there is some issue with the immune modulator therapy in these cases. I think Dr. Ananya would be in a better position. So, I think
increased level of that is the CD55. That is for
regarding the immune modulation, for the cancer cell, it is the T cytotoxic T cell. So CTLA study you can use, or you can use PD1, you can use PDL1. These are the immune modulators, right? Not
So
the
thank you.
complement.
So thank you, sir. I think we'll have to stop here regarding the discussion and go on to the second presentation. Thank you very much, sir, for your comments.
Yeah.
Thank you, Dr. Ananna, for your presentation. Now our next presenter, Dr. Apurva, are you there?
Yeah, here.
Okay, fine.
Am I
Dr.
visible
Apurva
to you?
is a postgraduate. Yeah, you're audible, you're visible. Dr. Apurva Pandit, she's a postgraduate student of Mandya Institute of Medical Sciences, Karnataka. Her topic is evaluation of soft tissue tumors by fine needle aspiration cytology and its correlation by histopathology, a retrospective study in a tertiary care center. Dr. Apurva, you may start your presentation.
Thank you.
Yeah.
Just a second. Are the slides visible?
Yeah, the slides are visible.
Okay, thank you. Good afternoon to respected judges and all the learners present here. Today I'll be presenting my paper on evaluation of soft tissue tumors by fine needle aspiration cytology and its correlation with histopathology. It's a retrospective study done in a tertiary care center in a medical college in Karnataka. Before we move on to the discussion about the study itself, let's have a brief introduction on what soft tissue is. Soft tissue is a non-epithelial tissue of the body made up by skeletal muscles, bones, fat, blood vessels, nerves, and supportive tissue. Embryologically, it's derived from mesoderm. Commonly, or the most common neoplasms that occur among mankind are the soft tissue neoplasms. They're a highly heterogeneous group of tumors that are classified by their line of differentiation according to the adult tissue that they resemble. Fine needle aspiration cytology, hence after called as FNAC, is minimally invasive, quicker, and provides a definitive diagnosis majority of the times. It preoperatively helps in differentiating benign and malignant lesions, allowing the clinicians to decide whether an extensive surgery is required, as to be done for malignant cases. Biopsy or histopathological examination remains the gold standard method for diagnosis, but is invasive and takes a longer time compared to FNAC. Objectives of my study were to determine the utility of FNAC in diagnosis of soft tissue tumors and correlate it with histopathology, to determine the factors leading to discrepancies between the diagnosis given by FNAC and histopathology. Coming to materials and methods, the study design is a retrospective record-based study done for 42 months. Records were accessed from January 2018 to June 2021 in the Department of Pathology, Mandya Institute of Medical Sciences in Karnataka. Institutional Ethics Committee approval was obtained before starting or commencing with the study. Sampling method universal, all records during the study period were included. A total of 1,239 FNACs were received for soft tissue tumors during this study period of 42 months. Although 74 cases out of these 1,239 underwent biopsy at our hospital and their specimen were received at our histopathological department. Data collection and analysis. The records of patients such as age, gender, site of lesion, and diagnosis were retrieved and analyzed. FNAC and histopathology slides were retrieved as well and analyzed and reviewed by senior pathologists. Data analysis was done using Microsoft Excel 2016. Frequencies of various variables were calculated. Coming to the age distribution of patients, since I mentioned total 74 patients underwent biopsy, henceforth we will be discussing only about these 74 cases. Out of this, majority of the soft tissue neoplasms were seen to occur in the 5th to 6th decade. Females were more affected than males. Coming to various locations, extremities was the most common site which was seen to be affected in our study. On FNAC, we were able to diagnose 50 cases of lipoma, 5 cases of giant cell tumor, 2 cases of schwannoma and neurofibroma each, and 3 cases of spindle cell sarcomas, which were thereafter confirmed by histopathology. 11 cases on FNAC were sent out as benign spindle cell lesion due to overlap between the various differential diagnoses. Among the lesions sent out as benign spindle cell lesion, 1 case belonged to that of spindle cell lipoma, which was diagnosed as a benign lesion, due to presence of spindle cell component within the tumor. When the sample was received or when specimen was received for histopathology, spindle cell components were seen to be admixed with adipocytes, thus leading to a confirmed or an accurate diagnosis of spindle cell lipoma. These are the various soft tissue tumors which were diagnosed on FNAC. As mentioned earlier, 50 cases were that of lipoma, followed by 11 cases of benign spindle cell lesion. Giant cell tumor were 5, neurofibroma and schwannoma each were 2 cases. 1 was osteochondroma and 3 spindle cell sarcomas were diagnosed. Same cases on histopathology. 51 lipomas were seen. As we can see, 1 lipoma has increased because the addition of spindle cell lipoma. Schwannoma have increased to 7. Giant cell tumor remained the same. Neurofibroma has increased as well. Hemangioma, there were 2 cases. Fibroma 1. Osteochondroma remained the same. Among the 3 sarcomas that we saw, we have 1 MPNST, 1 dedifferentiated liposarcoma, and 1 myxofibrosarcoma. The benign spindle cell lesion which we sent out on histopathological examination, accurate diagnosis were provided. 4 cases were that of schwannoma, 2 of hemangioma and neurofibroma each, and 1 belonged to spindle cell lipoma, fibroma, and low-grade myxofibrosarcoma. These are the images of spindle cell lipoma. Figure A shows FNAC smear, wet smear, fixed and then stained with HND. On 40x examination, a benign spindle cell lesion because of a cluster of benign spindle cells seen. Figure B shows HND of the formalin fixed specimen that we received. Here we can see that spindle cells are admixed with adipocytes, and thus this diagnosis of spindle cell lipoma was made. FNAC diagnosis which correlated with histopathology. Lipoma, giant cell tumor, schwannoma were correlated easily. Neurofibroma, osteochondroma were correlated as well. Among 3 spindle cell sarcomas that were sent out, as mentioned earlier, 1 was dedifferentiated liposarcoma.
1 minute left.
Thank you. 1 was myxofibrosarcoma and 1 was MPNST. This is an image of schwannoma on FNAC. Both, it was correlated. A and B both show Verroque bodies. Histopathology, both images, H and D stain, show multiple Verroque bodies with palisading of nuclei. There was a discrepancy between benign and malignant tumor in FNAC. 1 case diagnosed as benign turned out to be low-grade myxofibrosarcoma in histopathology. On further review of the slides, we concluded that the FNAC diagnosis was based on lack of ATP among the tumor cells, absence of mitosis, and lack of myxoid substance in the smears, probably because FNA sampling was done from a cellular area. HP allowed us to sample a larger area and thus showed the sheet-like arrangement of cells with hyperchromasia in a background of myxoid substance. This is the image of FNAC. Figure A shows a cluster of benign appearing spindle cells. This is an air-dried smear. Figure B is an HND smear or the wet fixed smear.
Your time is up.
Can I please complete
come to your concluding slide.
Yeah, coming. Just completing the line. There was no ATP, very mild degree of atypia. Same thing on confirmation with histopathology. We could see curvilinear vessels, multiple areas or large leaks of myxoid substances, mild to moderate pleomorphism, very rare mitotic figures. Again, a better 40x image. Conclusion, FNAC is able to diagnose most benign tumors as benign. Also helps us to differentiate between benign and malignant lesions in majority of the cases. In our study, we found the sensitivity to be 98.5% and specificity 80% and accuracy of 94.3%.
Okay, Dr. Apurva, I would request you to just close your presentation. Just, okay. So now, do we have any questions, Dr. Ankita?
No, ma'am, no questions in the chat box.
Okay, so apart from this particular case, you have any other difficulties in narrowing down your diagnosis? Did you perform any ancillary testing, any IHCs in case of your cell blocks or true cuts?
No, ma'am.
No. Okay, and any round cell lesions? Because it is very important before you do before the surgical excision is performed to categorize round cell lesions, isn't it?
Yes, ma'am, I agree. But within the study period, we did not receive any small round cell tumors. We did receive lymphoma cases, but it was lymph node and it was appropriately and timely diagnosed on FNAC as lymphoma. So we further did not do anything. Soft tissue neoplasms, none.
Okay, and retroperitoneum? Did you include retroperitoneal soft tissues over here?
Yes, ma'am. The case of dedifferentiated liposarcoma on
That one.
histopathology,
Apart
that
from
was
that?
retroperitoneal.
So apart from that, any other
No, ma'am.
single cell lesions or GIST or anything which you
No, ma'am.
suspected?
No, ma'am.
Okay. So I think we'll close regarding your presentation now. Thank you very much.
Thank you.
So, okay. So over to Dr. Ankita.
Yeah. Thank you, Dr. Apurva. So we move on to our next presenter. Dr. Arpita, are you there?
Yes, I'm here.
Dr. Arpita?
Yes,
You're there? Okay, you're audible, you're visible. So Dr. Arpita Bala is a second year postgraduate trainee from National Calcutta Medical College. Her topic is clinical pathological study of ovarian masses in adolescent girls and young women in a tertiary care hospital. Dr. Arpita, you can start your presentation.
Okay.
Yeah.
Is my slides on screen?
Yeah, it's visible.
May I start now?
Yeah. Do it in a slide show option.
Yes, I'm doing.
Yeah, you may start.
Okay. Good afternoon, all. I'm hereby presenting a clinico-pathological study of ovarian masses in adolescent girls and young women in a tertiary care hospital. Ovarian cancer, often called silent killer, is the sixth most common cancer in female population. Of all the malignancies encountered in female population, 15 to 20% are of ovarian nature. The incidence of pediatric ovarian neoplasm is 2.6 per 1 lakh girls. Ovarian malignancy in children and adolescents comprises approximately 1 to 2% of all childhood malignancies and 8% of all abdominal tumors in children. Ovarian malignancies are the most common genital tumor in children and adolescents, accounting for 60 to 70% of all gynecological malignancies in this group. Fortunately, most ovarian masses in adolescents are benign. Only 10% of ovarian lesions in adolescents are cancers. The objective of this study was to observe the frequency and clinicopathological patterns of various ovarian masses in female patients aged 20 years in a tertiary care hospital during a time period of 5 years from 2015 to 2020. Materials and methods. This is a retrospective observational study conducted in the Department of Pathology, Calcutta National Medical College for a time period of 5 years from January 2015 to December 2020. All cases of ovarian masses developed in patients up to the age of 20 years, which are received in our histopathology section in this time period, were retrieved from record file, and total 45 cases were found in this group. Patients' particulars and clinical details were collected from our departmental record file and from gynecology department. We made fresh sections from the routinely processed paraffin blocks and stained them with hematoxylin and eosine using standard procedure. Immunohistochemical stain was used when necessary. The result. During the 5 years of study period, total 45 cases of ovarian masses from our concerned age group were found. This pie diagram shows that the most common presenting complaint was vague abdominal pain followed by abdominal lump. Presenting ovarian mass size ranged between 3 cm to 21 cm with an average diameter of 10 cm. Only 2 cases are found bilateral, and surface breach of ovary was found in 17.7% cases. Of total 45 ovarian results, 40 cases were found benign and only 5 cases, that is 11%, were malignant. Malignancy was most prevalent above 10 years of age, that is 75%. Among all the ovarian masses, including both benign and malignant, 82% were cystic in nature and only 7% was solid. Of all benign ovarian tumors, 57% was unilocular cystic lesion and 35% was multilocular, while only 8% shows a solid cystic mixed type. Of all the malignant tumors, 60% cases showed solid nature on cut section and rest were of mixed type comprising of both solid and cystic component. Regarding the orogenic cell line of the tumors, surface epithelial tumors were found to be the most common variant, that is 19 out of 45 cases, comprising of 42.2% of all cases, and closely followed by germ cell tumors, which are 14 out of 45 cases. Among the surface epithelial tumors, the most prevalent type was mucinous cyst adenoma, that is 47.3%, followed by serous type of cyst adenoma. And in the tumors from germ cell origin, the most common type found in our study was mature cystic teratoma, that is 78.5%. Majority of malignant tumors, that is 60%, were found from germ cell origin, and the rest were from sex-cord stromal tumors. Here are some histopathological pictures from our study. The section showing mucinous cyst adenoma. This section is a case of yolk sac tumor, and this is Schiller duval body in case of yolk sac tumor. This is focal positivity of immunohistochemical staining for alpha-fetoprotein in a case of yolk sac tumor. And this is a case of mature cystic teratoma showing features of bone formation with hematopoiesis inside. And this is also a case of mature cystic teratoma with development of different types of tissues like cartilage, stratified squamous epithelium. And this is a case of choriocarcinoma with extensive tissue necrosis. Now discussion. The ovary gives rise to a wide variety of tumors with varied presentation. A few patients with early stages of tumors were asymptomatic or presented with precocious puberty, but the main presenting symptoms of patients with ovarian masses are abdominal pain and abdominal distension. Ovarian neoplasms with cystic appearance are seen to be mainly benign in nature, while in malignant counterpart had predominance with solid consistency. During infancy and childhood, the predominant types of ovarian neoplasms are those from germ cell origin, such as teratoma, dysgerminoma, and endodermal sinus tumor. But in adults, the epithelial neoplasms are the most common. The incidence of surface epithelial tumors published in most world literature is usually 15 to 20% in prepubertal age group and adolescents age group. In our study, the commonest tumors were surface epithelial tumors, that is 42.2%, and closely followed by germ cell tumors, that is 31.1%. Same as the findings of another study by Veloches et al. In 2008. Ovarian malignancy in children and adolescents is reported in 10 to 20% of all ovarian masses or neoplasms. In this study, of total 45 cases, 88.8% lesions were found benign and only 11.1% were malignant. Among all the malignant tumors, the majority were germ cell tumors, that is 60%, followed by sex-cord stromal tumors. Malignant counterpart comprises 21.4% of all the germ cell tumors. Similar studies by Bhattacharya and K et al. In 2010 and Resi et al. In 2004, based on the childhood tumors, reported germ cell line malignancies to be the most prevalent amongst all ovarian cancers. Mature cystic teratomas account for half of ovarian neoplasms that appeared in first 2 decades of life. In our study, mature cystic teratoma was the most common tumor found arising from the germ cell line, that is 78.5%. But
1 minute left.
But none of them showed a malignant feature. Conclusion. So from this study, we can say that ovarian neoplasms in early age are mainly of benign type, and malignant variety is a comparatively rare entity. The incidence, histological distribution, and clinical presentation of these tumors is distinct from those in adults. Early correct diagnosis and preservation of fertility should be the aim. It is a high time to address the issue in our community, as patients are not only belong to a tender age group, there are important questions related to their future fertility and quality of life as well. Support and sensitivity for the frightened girl and her family is essential, as is high quality decision making by the diagnosing pathologist and gynecologist. And here are the reference studies. Thank you.
Thank you, Dr. Arpita. Do you have any questions in the chat box, Dr. Ankita?
No, ma'am. No questions.
Okay, just one comment, Dr. Arpita, like you have rightly pointed out, like here there should be minimally invasive surgery to preserve the fertility of the individuals. Now, in your cases, what was the correlation between the imaging studies, pre-operative, or any hormone studies or tumor markers were done prior to the surgery to come to to narrow down the diagnosis prior to surgery? Could you correlate this with your imaging or your prior to the histopathology being done or the surgery being done?
Actually, ma'am, I have mentioned in the methodology that this is a retrospective study. I have collected the data only from the record files. So only the complaining, presenting complaints and the age, etc., which was there in record file, that was only available. So all the radiological findings and the hormonal levels, etc., was not found and was not included in our study.
Thank you very much, Dr. Arpita. I think we'll go on to the next speaker now.
Thank you.
Yes, ma'am. Thank you, Dr. Arpita. So we'll move on to our next presenter. Dr. Hetal, are you there? Dr. Hetal?
Yes, I'm there.
Okay,
Can you
fine.
hear me?
Yeah, you're audible, you're visible. Dr. Hetal Kirit Shah is a postgraduate student. Her topic is histomorphological spectrum of CNS lesions in a rural tertiary care hospital. Dr. Hetal, you may start.
Okay, my topic is histomorphological spectrum of CNS lesion in tertiary care hospital. Um, CNS lesions are show considerable geographical and racial variation in respect to incidence and their pattern of distribution. Many neoplastic lesions can clinically and radiologically brain tumors, and to differentiate them, histomorphological examination is necessary. The histological spectrum of CNS lesion is broad and it varies among extremes of ages. CNS lesion account for 2% of all cancers, and there has been a rapid increase in incidence of CNS tumors. The aim of this study was to study the histomorphological spectrum of CNS lesion in tertiary care hospital to differentiate between neoplastic and non-neoplastic lesions on histopathology, and to classify them according to WHO classification and to describe their clinical presentation. This is a descriptive cross-sectional study carried out from March 2020 to February 2021 in the Department of Pathology. The cases were diagnosed histopathologically and characterized wherever necessary using immunohistochemistry and categorized according to WHO classification 2001. In results and discussion, non-neoplastic versus neoplastic, we found that there were only 10%, that is 3 cases that were non-neoplastic, and 90% that are 27 cases were of neoplastic lesions. In comparison with our present study, correlated with other studies done by Joshi et al. And Rathore et al. And Kogla et al., where neoplastic lesions were more than non-neoplastic, but in Joshi et al. And Rathore et al., they were a little more than the present study. In morphological distribution, astrocytoma and glioblastoma were the most common, comprising of 22.2% of cases, followed by meningioma, which comprised of 11.1% of cases. Glioblastoma, medulloblastoma, hemangioblastoma, ependymoma, and schwannoma comprised of 7.4% of cases, 2 cases each, and one was non-Hodgkin's lymphoma and one was pituitary adenoma. In astrocytoma, we had diffuse astrocytoma and pilocytic astrocytoma, and in ependymoma, we had consisted of anaplastic ependymoma and classical ependymoma, and in non-neoplastic lesions, subdural empyema, AV malformation, and brain abscess were in one frequency. In comparing with histological type with other studies, neuroepithelial tumors were the most, consisting of 66.6%, that are 19 cases. These findings correlated with all other studies except study done by Lee et al. That showed meningeal tumors to be the most common, giving 31.2%. Meningeal tumors in our study was 11.1. Cranial and spinal nerve tumors were 7.4. Cellular region tumor and lymphomas were 3.7% of cases, and metastatic were 0. In WHO grading, in the present study, grade 4 tumors were the most common, 9 cases, comprising of 33.4% of cases, and grade 1 and 2 were 8 each, consisting of 29.6% of cases. This was in contrast with other studies done by Mehta et al., Desai et al., Vimal et al., who had grade 1 tumors most common. In age distribution, our most common age group was 11 to 20 years, consisting of 7% of cases. But in astrocytoma, it was more common in 31 to 40 age group. The present study, most common age group was 11 to 20, but in other studies done by Ariel et al., Desai et al., Rathore et al., the most common age group was 31 to 40, 41 to 60, which was in contrast with our study. In pediatric and adult distribution, 6 cases were pediatric, most commonly being medulloblastoma and glioblastoma. And in adults, there were 24 cases in which astrocytoma and glioblastoma was the most common. Comparing it with other studies, pediatric cases, it was similar to other studies done by Niboria et al. And Kongla et al., where around 20% of cases were pediatric and 80% were adult studies. In gender distribution, are 30 out of 30 cases, 17 were males and 13 were female, where male to female ratio being 3.1 to 1. In astrocytoma were more common in males and glioblastoma were more common in females. So in comparison with other studies, all studies had similar findings with a little preponderance of male distribution, while study done by Arya et al. And Lee et al. Showed a preponderance
1 minute
of
left.
Location and laterality wise, frontal lobe and frontoparietal lobe were the most common cases, and male distribution was variable more than female distribution. Frontal, parietal, and temporal constituted of the main cases location. Summary wise, these 30 out of 30 cases, 3 were neoplastic, non-neoplastic, and 27 were neoplastic. Overall, neuroepithelial tumors were the most common entity, and among 30 cases, 17 were male and 13 were female. Frontal lobe was the most common site for neoplastic lesion. Most common age group was 11 to 20, and age varied from 7 to 66 years, with the mean age being 32.7 years, and headache was the most common presentation. This study highlights the histological diversity of the CNS lesion in both pediatric and adult, and the spectrum of neoplastic lesion consisted of astrocytoma, glioblastoma, ependymoma, hemangioblastoma, medulloblastoma, meningioma, non-Hodgkin's lymphoma, oligodendroglioma, pituitary adenoma, schwannoma, and in non-neoplastic, AV malformation, brain abscess, epidural, subdural empyema. These are my references.
Okay, thank you, Dr. Hital. Do we have any questions in the chat box, Dr. Ankita?
No, ma'am, no questions.
I have no question. I have no question. I'm Dr.
Yes, ma'am.
Amita Giri.
Yes,
I
ma'am.
have no question, but I just want to know. She has done a very good job. So I just want to know from which institution she has come. We couldn't get it.
I'm a third year postgraduate student from Pravra Institute of Medical Sciences.
May I comment one thing? That yeah, I did work on the epidemiological and types of intracranial lesion. Of course, it was in 1993, and in the Bangor Institute of Neuroscience where I was there. And I found that most of the common tumor, intracranial tumor, is a metastatic, and followed by the meningioma and then the astrocytoma. And however, this sample size is very low. And yeah, we had the sample size of more than thousands. So that ultimately varied probably with these findings. And it is also that has a references in the Ramanna books of the neuroscience, neurologists, neurosurgery.
Thank you, sir. Dr. Hital, did you perform any IHC for categorization?
Yes, ma'am. Wherever necessary, I had performed IHC. So during lymphoma, we performed LCA and T cell, B cell markers. And in other tumors also, we performed wherever necessary.
And any difficulties you faced to differentiate between low-grade astrocytomas and gliosis?
Yes, ma'am. We did face that, but mitotic count and but ultimately we reached a conclusion.
Okay, thank you very much, Dr. Hital. So, Dr. Ankita, I think we'll proceed to the next speaker.
Okay, ma'am. Thank you, Dr. Hital. So we'll move on to our next presenter. Dr. Karishma, are you there? Dr. Karishma, are you there?
Yeah, I'm there. Can you hear me?
Your volume is low. Can you increase it? So Dr. Karishma Dayanand is from MIMS Mandya. Her topic is histopathological spectrum of skin lesions analyzed in a tertiary care hospital, a record-based study. Dr. Karishma?
Can you hear me now?
Yes, your volume is low. I think you should increase your volume or you put your earphones properly.
Yeah, now you can hear me?
Yeah, you're audible. You can start your presentation.
Is my PPT visible?
Yeah, it's visible. You go on to your slide show mode. Yeah, it's visible. You may start. Yeah.
Good afternoon, everyone. I've chosen a topic for my paper as histopathological spectrum of skin lesions analyzed in a tertiary care hospital, which was a record-based study. I'm Dr. Karishma from Department of Pathology from Mandya Institute of Medical Science. Introduction: prevalence of skin lesions is common in developing countries. The pattern of distribution varies from country to country. Dermatological disorders are one of the frequently encountered health disorders in the tropical countries, especially India, with varied spectrum depending on the geographical domicile. The spectrum of cutaneous disorder is highly variable. However, clinical presentation is restricted to a few changes such as hyperpigmentation, macules, papules, nodules, etc. Each clinical presentation is common to different histopathological pictures and thus definitely requires a histopathology for their confirmation. Hence, the standalone clinical diagnosis is often difficult for different entities. Accurate diagnosis is needed for proper management of different skin disorder which presents with similar signs and symptoms. Hence, histopathological examination has become the valuable tool in the diagnosis of different skin lesions and in the management of the patient. The aim of our study was to determine the incidence as well as the distribution of various skin lesions based on the histopathological observation. Materials and method used. It was a retrospective descriptive study which was carried out in the Department of Pathology with a sample size of 334. All the skin biopsies which were sent to our department during the study period, that is 24 months, from January 2019 to December 2020, were taken as a study sample. The study was conducted only after getting approval from the Institutional Ethics Committee. Inclusion criteria. I have included all the biopsies, that is both punch as well as excision biopsy, with the definitive diagnosis. Exclusion: any case which didn't have a definitive diagnosis or which were reported with differential diagnosis were excluded from our study. Results: a total of 334 skin biopsy specimens were received in our lab during the study period. Out of these 334 cases, only 310 cases were found to have a definite histological diagnosis. This is the distribution of cases based on the histopathological diagnosis. So in my study, I got a maximum number, that is 86.9% non-neoplastic patient. Then I got non-specific diagnosis, which had to be correlated clinically. Later was the neoplastic patients. Distribution of the skin lesion based on the gender of the patient. In my study, I got male predominance more than female. The ratio was 1.2:1, and the mean and most of the skin lesions were having male predominance, but few such as the metabolic lesions, inflammatory diseases of cutaneous adnexa, and benign adnexal epidermal tumors had female predominance. This is the distribution of skin lesion based on the age of the patient. Maximum number of skin lesion came under 41 to 50 years. Exceptions were papillosquamous lesion, which came under 31 to 40 years and accounted for 19.2%. And this is a type of various skin lesion which were encountered. Hello, can you hear me?
Dr. Yeah, please continue.
which had a different dermatological locations. That is, the most common lesions were the papillus mammals, the maximum were the lichen planus and psoriasis. The next common lesions were the most common were the lepromatous leprosy and tubercular leprosy. Next were the vestibular and pustular lesion, that is the pemphigus foliaceus, was the more common. Neoplastic lesion, the common lesion cell carcinoma and basal cell carcinoma were reported in our study. This is the lesions, that is the neoplastic lesion, which accounted for 6.3%. The most common was squamous cell, then was basal cell, and keratoderma were the common lesions. Papillosquamous diseases accounted for 30.5%, most common being the lichen planus, then is the palmoplantar psoriasis, then being the lichenitis. Vestibular bullous and pustular lesion, the most common being the pemphigus foliaceus and then pemphigus vulgaris and bullous pemphigoid. Microbial diseases, most common being the tubercular leprosy and lepromatous leprosy. Cystic lesions, the most common was epidermal cyst, then coming to the sebaceous cyst and then the tricholemous cyst. Vascular diseases were leukocytic vasculitis. Connective tissue diseases were nausea. Metabolic diseases were cutaneous calcinosis cutis. Inflammatory disease of cutaneous aggressor was a keloid. Benign aggressor tumors being pilomatricum. Anatomic distribution of the dermatomes, the most commonly, all the skin lesions were most commonly seen in the extremities, that is in the upper limb as well as the lower limb. Next, it was seen in the thorax and head and neck, and then in the abdomen and pelvis. This is the picture of lichen planus. The first picture is of a 10x, where it is where it's showing acanthosis, hypergranulosis, parakeratosis, and around the retinal ridges he was having inflammatory infiltrate, that is predominantly being lymphocyte. This picture B depicts melanin incontinence and lymphocytic infiltration. This is a picture of squamous cell carcinoma displaying tumor cells which are arranged in sheets, and few keratin pearls are also noted. This is a picture of seborrheic keratosis, that is under 40x, displaying hyperkeratosis and keratin horns. This is a picture of leptomatous leprosy under 10x, which is showing vein flow between the epidermis and the dermis. The picture S, that is the 5 ferrocosine under 100x, is displaying plenty of dot-shaped eosinophilic bacilli. Intradermal nevus under 10x is displaying tumor cells, especially in the upper epidermis, and pigment incontinence, pigmentation is present in the dermis. This is a picture of melanoma under 40x, displaying dysplasia melanocytes with prominent pigmentation.
1 minute left.
This is a picture of chromoblastomycosis under 40x. Plenty of brown sclerotic bodies, that is copper-penny bodies, are also noted. Discussion: a total of 334 cases were included in the study. Out of this, 310 had a definitive diagnosis, and the rest of the cases, no definitive diagnosis was seen. Out of these 310 cases, 170 were males and 140 was females. In our study, maximum number of cases belong to 41 to 50 years of age. This is the comparison table showing in our study we included 334 cases. Study period was 24 months, and male to female ratio was 1.2:1 with age distribution of 41 to 50 years. Most common lesion was the papillosquamous lesion was lichen planus, microbial infection was lepromatous leprosy, and vestibular lesion was pemphigus foliaceus. Cystic lesions was the epidermis. Neoplasm was SCC. Site most commonly involved was extremities. Sant Charles et al. He had 133 cases. His study period was 6 months, and females were most commonly involved. 41 to 50 years was.
Your time is up.
I'll go to the conclusions.
Conclusion slide, please.
This study shows that the histopathological examination of the skin biopsies in correlation with the clinical history aids in the accurate diagnosis of majority of skin lesions. In spite of all the efforts as pathologists, there are some limitations wherein a few cases have to be categorized as non-specific. Follow-up and re-biopsy from a representative site could overcome these limitations. These are my references. Thank you.
Thank you, Dr. Karishma. Do we have any questions in the chat box, Dr. Ankita?
No, ma'am. No questions.
Okay. So just a query. Sir, please carry on.
Yeah. Did you not find any fungal lesions in the skin?
Fungal lesion, sir, apart from chromoblastomycosis, we didn't find anything.
Any histoplasma?
No, so we didn't find any histoplasma.
Okay.
Dr. Karishma, how many your histopathology reports altered the clinical diagnosis? Were there any reports which altered the clinical diagnosis?
Yes, ma'am. Actually, when they send for us for anything like skin biopsy, they send with a differential diagnosis, but 10 of them didn't match with the diagnosis which the dermatologist had sent.
Regarding vesiculobular lesions or your infectious lesions, did you perform any ancillary tests or immunofluorescence or anything to confirm the diagnosis
No,
or
ma'am.
categorize specifically?
No, ma'am.
Okay.
Actually,
Okay,
IgA should be done.
Yes.
Okay, so thank you very much, Dr. Karishma. We'll go on to the next speaker. Dr. Ankita, please.
Yeah, ma'am. Thank you, Dr. Karishma. So we'll move on to our next speaker, Dr. Mohammad Abdullah. Are you there? Dr. Mohammad Abdullah.
Yes, madam. Am I audible?
Yeah, you're audible, you're visible. So Dr. Mohammad Abdullah is from ESI PGI MSR Moniktola. His topic is pattern of serum protein electrophoresis. So you may start your presentation.
Is my presentation visible in the screen?
Yeah, it's visible. You go to the slideshow mode.
Okay, good afternoon, respected judges and lauded audience. I am Dr. MD Abdullah. I am going to present a paper on pattern of serum protein electrophoresis.
Any issues?
Yes, okay, it has gone. Now the introduction. Serum protein electrophoresis is a method of separating protein based on their physical properties.
Doctor, your slide is not visible properly. Like you're moving to the next slide, but you're on the screen, it's still on the first slide.
Oh, maybe it due to some internet connection problem. Can I switch off my video?
Yeah, sure. You switch off your video.
Okay.
Do you want Mr. Deepak to present it, or you will present it?
Is it visible properly, my presentation? The second page is visible?
It's visible. No, it has not moved to the second page. Mr. Deepak, are you there? Mr. Deepak? Mr. Deepak?
Hello, am I audible?
Yeah, you're audible.
Yeah,
Can
Mr.
you help?
Abdullah, Mr. Abdullah, the thing
yes.
is that I am running your PPT. You will just say when you want me to move on to the next slide, you will just say next slide. That's it.
Okay, sir.
Okay. You stop the sharing. I'll do it for you.
Dr. Abdullah, stop sharing.
No need, I will stop it.
Okay, fine.
Now is it visible?
Yeah, it's visible.
Okay, please next slide. Hello, Mr. Deepak. Yes, okay. So electrophoresis is a method of separating protein based on their physical properties. Serum is placed in a specific medium and charge is applied. The net charge, the size and shape of the protein is commonly used in differentiating various serum proteins. Next slide, please. Okay, the objective of this study was to identify patterns of serum protein electrophoresis in a tertiary care center and to evaluate immunofixation patterns of M band and to quantify M protein for categorization as well as therapeutic monitoring of plasma cell neoplasm. Next slide, please. Now, the materials and method. Study design was a retrospective observational study and study population were patients of ESI Hospital, Maniktola, and duration of study was 5 years. Next slide, please. Inclusion criteria were the suspected cases of plasma cell neoplasm and chronic lymphoproliferative disorder follow-up cases of multiple myeloma for therapeutic monitoring, and unexplained increase in serum globulin with altered AG ratio. Exclusion criteria was incomplete or inaccurate patient information. Next slide, please. Okay, this the records maintained in the pathology department was our method of data collection, and here in the screen it is the various instruments which were utilized during data collection is mentioned here. This is the staining material, and this is the adapter. This is also the adapter, and these are the buffer strip and agarose gel film. Next slide, please. Please go on to the next. Okay. Now we collected the blood from the patient and then in a clot vial, and then centrifuged at a speed of 1200 rpm for 2 minutes, and the serum just separated out was placed on the agarose gel film, and then the agarose gel film was placed in a machine named as Hydrosis 2 of Sebia company, and then the protein got separated out, and after separation protein was stained by amidoblast. The same thing is used for the immunofixation study, except that the plasma the serum which was obtained was first diluted with the help of diluent, and then it was after separating anti-sera to heavy chain isotypes such as alpha, gamma and the mu, and for the light chains such as kappa and lambda was applied, and the staining was done with the help of acid violet. Next slide, please. This is the machine which we use for this procedure. Next slide, please. These are the scanner for scanning the agarose gel film in which the protein gets separated out, and this is the computer and the printer for reporting of that sample. Next slide, please. Okay, this is a case showing the presence of M band. Please go on to the next slide. This is a case showing 2 M bands. Next slide, please. This is a photograph of the immunofixation study showing an IgG and kappa as a immunoglobulin M protein. Next slide, please. So the results were a total number of cases were 455, and 307 patients were male and 148 were female patients, and 71% of our study population was patients of more than 50 years of age, and 28.4% were patients of less than 50 years of age. Next slide, please. This is the pattern of serum protein electrophoresis. We got 39% of our cases which were showing M band in their serum protein electrophoresis, and 41% cases that was showing a normal pattern, and in 20% of cases that were showing the polyclonal pattern. Next slide, please. This is a pie diagram showing distribution of study population according to the heavy chain, and we got 91% cases with gamma as their heavy chain, and followed by alpha heavy chain in 7% of the study population, and 2% cases were showing the mu heavy chain. Next slide, please. The distribution of light chain in our study population was the most common light chain was kappa, constituting 55%, followed by lambda. Next slide, please. So in the nutshell, which I have mentioned in the form of pie diagram, this the same thing is mentioned here in a bar diagram. Next slide, please. Okay, this is a patient bar diagram showing patient distribution according to both heavy and light chain. So the most common immunoglobulin present in our study was the IgG and kappa, which was about 47.46%, followed by the IgG lambda consisting of 42.94%, and we don't got any case of IgM lambda. Next slide, please. This is a table showing the indications of doing SPP in this patient.
1 minute left.
And 56% of cases came for diagnosis purpose, and rest of them, the patient came for response assessment. Next slide, please. The final diagnosis of all cases showing M band in the serum protein electrophoresis was the most common diagnosis was the multiple myeloma, forming 91%, followed by the chronic lymphocytic leukemia, 5.7%, and then the collagen vascular disease, 2.3%, and at last but not the least, the Waldenström's macroglobulinemia, 1%. Next slide, please. So the most common heavy chain in our study was the gamma heavy chain, and these are the study done by on the related topic by other authors, and they have seen they are consistent with our finding. The second most
time
common
is up. Move on to
Abdullah,
your...
please come to your conclusion slide. Conclusion slide.
Okay, the IgG kappa was found to be the most common antibody, followed by the IgG lambda, and detecting M band does not immediately conclude the diagnosis of plasma cell neoplasm. Even benign disorders like collagen vascular diseases are to be considered. Okay, thank you.
Thank you, Dr. Abdullah. It is open for discussion, please.
Okay, Dr. Abdullah, what is the percentage of the Waldenström macroglobulinemia in your cases, and what type of band you have found?
Sir, we got only 1% of patients.
What the band is?
It was in the M band present.
M band?
IgM was the heavy chain, and kappa was the light chain.
And in smoldering multiple myeloma, did you get any?
Sir, actually, in this study, what we done that after doing the immunofixation study, we found that if there is antibody present, then we included it into multiple myeloma cases.
How many percentage of smoldering multiple myeloma you found?
Actually,
because it is increasing now.
Yes, sir. We do not we do not got any cases relating smoldering.
So if you would get, what would the band?
Yes, sir.
Smoldering. If you would get, what would be the band? Smoldering. What would be the band?
It will be the. It may show the M band, but the band size will be small.
It is not found in the M band, so it is called smoldering. Right. Okay.
Okay, thank you, sir. I think we need to close the discussion now. Thank you, Dr. Abdullah. We'll go on to the next speaker.
Thank you, Anna.
Okay, ma'am. Dr. Preeti, are you there? Dr. Preeti?
Yes, ma'am.
You're there?
Yes, ma'am.
So you're under the name of Harshul Sharma?
Yes, ma'am.
Okay, fine. So Dr. Preeti Sharma is PG resident. Her topic is histomorphological spectrum of skin adnexal tumors, a study at tertiary care center. Dr. Preeti, yes. You may start your presentation.
Ma'am, am I visible?
Yeah, you're visible, you're audible. You may start.
Ma'am, my PPT.
No, your PPT is not visible.
Ma'am, now?
No. Mr. Deepak, do we have a presentation with us? Mr. Deepak? Okay, Mr. Deepak, can you, Dr. Preeti, Mr. Deepak will start sharing your presentation.
Yes, ma'am. Yes, ma'am, please.
Okay, yeah.
Yes, ma'am.
Okay, so
A
when
very
you
good
when
afternoon
you
to
go
all
to
the
the next
respected
slide,
judges. Yes, ma'am.
when you go to the next slide, just say next. They'll change your
Yes, ma'am.
slide. Okay.
Yes, ma'am.
Okay.
Yes, ma'am. Very good afternoon to all the respected judges. Myself, Dr. Preeti Sharma from Jhalawad Medical College, Jhalawad, Rajasthan. My topic is histomorphological spectrum of skin adnexal tumors, a study at Tertiary Care Center. Next, please. The introduction is the skin adnexa is made up of a variety of cells that can lead to a variety of cancers. Sebaceous glands, eccrine and apocrine sweat glands and hair follicles are among them. Skin adnexal tumors are most typically found in the head and neck, trunk and extremities. Solitary and numerous papillonodular or cystic lesions are possible. Multiple tumors can be used as a sign of internal visceral cancers, although most skin adnexal tumors are benign tumors that are locally aggressive, can mimic primary cutaneous neoplasm. Malignant ascites, on the other hand, are uncommon and must be distinguished from the cutaneous metastasis. Importantly, refer to adnexal tumors as a troublesome tumors, and they pose a significant diagnostic challenge for both surgeons and pathologists because they encompasses a wide range of skin epithelial tumors, including hamartoma, hyperplasia, benign and malignant tumors that can arise from or differentiate toward adnexal epithelial structures. Next, please. Multiple tumors are generally associated with an inherited disease, such as multiple trichomomas in Cowden syndrome and sebaceous adenomas in Muir-Torre syndrome. Malignant skin adnexal tumors are uncommon, locally aggressive, and can lead to nodal involvement and distant metastasis, all of which have a bad prognosis. As a result, establishing a cancer diagnosis in ascites is critical for both therapeutic and prognostic consideration. The spectrum ranges from a benign adnexal tumor that is cured with excision to a malignant counterpart that is locally aggressive and has a potential for distant metastasis. The adnexal tumors arise from the pluripotent stem cells and that differentiate along one or more primary adnexal structures. Skin ATs are infrequently found on fine needle aspiration cytology because most doctors prefer to diagnose suspected skin ATs by excisional biopsy. Subtyping it enables for proper patient management and follow-up. Please next. Next. My objectives are to study the histopathological spectrum of skin adnexal tumors at a tertiary care center and to correlate adnexal tumors with age, sex, location, differentiation, and pattern. Next. Material and methods. My study was hospital-based descriptive observational study. The study duration is October 2020 to March 2021. Study place Department of Pathology, Jhalawad Medical College, Jhalawad, Rajasthan. My sample size was 40 biopsies of clinically suspecting skin adnexal tumors. Next. Methodology. The patients were suspected with skin adnexal tumors were invited to take part in the study. This study was done on them with explained in the details to them and informed consent was obtained. The patient fulfilling the inclusion criteria which is given followed were listed. The biopsy was taken and it was routinely processed under histopathological routinely processed for histopathological examination and the statistically analysis is done. Next. My inclusion criteria is all skin biopsy clinically suspecting as skin adnexal tumors. Exclusion criteria is inflammatory condition, inadequate biopsy, cyst and tumor-like lesions. Statistical analysis is done. Next. Results. Out of total 40 cases of skin adnexal tumors were included in the present study, in which 90% were benign and 10% were malignant. There is female preponderance with 55% of female and 45% of male cases. And 75% of study subjects were solid, 15% were solid and cystic, and 10% were cystic. 30% study subjects had nodular heteroadenoma, 20% subjects had pilomatricoma, 15% subjects had eccrine poroma, 10% each had trichoepithelioma and eccrine porocarcinoma, whereas 5% subjects each had trichoblastoma, trichofolliculoma, and eccrine spiroadenoma. 40% subjects has basaloid pattern, 30% has basaloid and clear cell pattern, 55% subjects were pilar, and 30% were eccrine, 10% shows sebaceous tumors, and only 5% had apocrine differentiation. Next. This is the tabulated form in which the behavior of the tumor is shown as a benign or malignant, in which there is 90% are benign and 10% were malignant. Next. In the other, there is age distribution of the cases, in which the most common age group is 31 to 40 year of age, in which there is incidences are 25%. Next. The distribution of skin adnexal tumors according to the morphological pattern, in which there is maximum are solid, which is of 75%, 15% were solid and cystic, and 10% were solid cystic. Next. There is distribution of tumors according to the direction of differentiation, from which there is maximum is there is follicular or pilar differentiation with 55%, then eccrine
1 minute left.
Eccrine were 30%, sebaceous were 10%, and apocrine were 5%. Next. There is a distribution of adnexal tumor according to the histopathological diagnosis, in which there is the most common tumor found was nodular hydranoma with percentage of 30%. Next. Distribution of skin adnexal tumor according to the cellular morphology, in which there is maximum, the pattern we found is there is basaloid pattern with 40% of all cases. Next. There are photomicrographs of nodular hydranoma, eccrine porocarcinoma, and eccrine poroma, pilomatricoma, trichofolliculoma, and eccrine spiroadenoma. Next. Conclusion, we conclude that skin adnexal tumors are relatively rare. Most common age group is 31 to 40 years. There is slight female preponderance. Head and neck were frequent sites for occurrence of these tumors, among which face is the commonest site. Majority of adnexal tumors were solid. Nodular hydranoma is the most frequently encountered among the all skin adnexal tumors. Skin adnexal tumors cannot be diagnosed on the clinical ground only, and the histopathological diagnosis plays a major role in diagnosing these tumors. These were my references. Thank you so much.
Okay. In your presentation, you have twice told that it has got the female preponderance. What is the cause? What is the mechanism? Why?
Sorry, sir. Can you repeat the question? Sorry, sir.
In your presentation, you have twice told that it has got the female preponderance of 55% or like that. Why the female preponderance? What is the reason behind female preponderance? Actually, this tumor arises from the stem cells.
Yes.
Then why female preponderance? Is there any relation with the hormone?
Sir, mainly, sir, estrogenic stimulation is more in females.
But it is probably, if I am not wrong, it arises from the stem cells present in the skin.
Yes.
Does it affect? Estrogen does affect on the stem cells.
Yes.
Right. Okay. Okay, thank you, sir. I don't think we'll be able to take any more questions with this. We'll be closing now. Thank you, Dr. Preeti. And Dr. Ankita, we'll go on to the next speaker.
Thank you, ma'am.
Yes, ma'am. Thank you, Dr. Preeti. Dr. Probir, are you there?
Yes, hello. Yes.
You're there?
I am audible. Hello.
Yeah, audible. You're audible.
Okay.
Dr. Probir is PGT. His topic is clinical, radiological, cytological, and histopathological correlation in the diagnosis of solitary thyroid nodules. Dr. Probir, you may start your presentation.
Okay. Okay.
Yeah, it's visible. You go to
Okay.
your slide share mode.
I have gone to slide share mode.
Okay,
My
slideshow. Now go for the slideshow.
Title page.
If it's possible.
Hello.
You may start. You may start. Yes.
Yeah, there is.
Okay. Good afternoon. My topic is clinical, radiological, cytological, and histopathological correlation in the diagnosis of solitary thyroid nodules. Now, I am discussing about my topic very shortly. Thyroid gland is unique among all endocrine glands.
Dr. Praveen, your next slide is not visible.
Is it visible?
Do you have it, Mr. Deepak?
Yeah.
Yeah, okay, fine. Then Dr. Praveen, you stop sharing. Mr. Deepak will share the slide.
Okay.
Is it visible?
Okay.
Yes, it is visible.
Okay, when you want to go on to the next slide, you just said me next. Okay. You just say me next. Okay.
Okay. Next. I am discussing my topic very shortly. Thyroid gland is a unique among all endocrine glands. Because of its superficial location, it is amenable for direct physical examination and cytological and radiological evaluation, and if necessary, then histopathological study. Next, thyroid diseases affect a woman more commonly than men. The diagnosis of thyroid lesions using aspiration cytology was first reported by Martin and Ellis in early 1930. The routine use of FNAC in the assessment of thyroid lesions has reduced the number of patients subjected to thyroidectomy for benign lesions. So solitary thyroid lesions are suspicious for malignancy in FNAC, may or may not be neoplastic on histopathology. Next, aims and objectives. To study the spectrum of thyroid lesions, correlate between clinical, radiological, cytological, and histopathological findings of solitary thyroid nodules. Next, materials and methods. This was a prospective study conducted on 75 cases of solitary thyroid nodules in Calcutta National Medical College Pathology Department. In all patients clinically and radiologically diagnosed as solitary thyroid nodules, 5-needle aspiration cytology and histopathology was done. Next, inclusion criteria. All patients with palpable thyroid swellings, irrespective of age and gender, with thyroid swelling who have undergone thyroid surgery. Non-palpable lesions are studied through ultrasound and CT-guided FNAC. Next, exclusions criteria. Thyroid swellings with toxic features and thyroid those patients with thyroid swelling who do not give consent for thyroid surgery. Next, results. In our study, females cases outnumber of male cases. The ratio of female and male is 11.5:1. A total of 75 patients with various thyroid lesions were diagnosed and treated at our hospital during the period of July 2019 to June 2021 were taken into consideration. In all cases, preoperative FNAC was done and diagnosis was recorded. Out of 75 cases, 46 cases were operated and histopathological correlations were done. Next. Table 1 shows the distribution of thyroid lesions according to sex. Here, the male is more less than the female. The male is 6 and the female is the 69, shown in the bar diagram. Next. The table 2 shows the distribution of thyroid lesions according to age. The bar diagram shows that 30 to 39 years of age group are more affected population in the study. Next. The FNAC report shows the benign lesions are nodular goiter and papillary carcinoma in case of neoplastic lesions as more. Next. Whereas in the histopathology report, the seen that multinodular goiter and the papillary carcinoma of thyroid is prevalent among all the thyroid lesions. Next. Now, the benign thyroid lesions, the photomicrograph shows lymphocytic thyroiditis, where thyroid follicles shows anisonucleosis, lymphoid and plasma cell in the background, and colonization of lymphoid cells in the follicle. And the counterpart shows the Hashimoto's thyroiditis, where lymphoid follicles with predominant germinal centers and oncocytic follicular epithelium. Next. This photomicrograph shows the comparison of FNAC and histopathology of papillary carcinoma of thyroid. The papillary carcinoma of thyroid on FNAC on MGG stain shows the nuclear features of papillary carcinoma, like the nuclear optical clear nuclei and pseudo-inclusion and nuclear groups, where in the papillary carcinoma thyroid on histopathology, H stain shows the papilla and the ground glyph or optically clear nuclei. Next. To conclude, based on the cytological findings, the patients can be followed in case of benign diagnosis, and in malignant lesions, go for surgery, thereby decreasing the rate of unnecessary surgery. Next. These are my references. Thank you.
Thank you, Dr. Roy. I just had a query, like, did you classify according to the Bethesda system, or did you compare, since you're writing clinical and your radiological, all that correlation with the USG, the thyroid score and all that? Did you compare with that? And another thing is, why did that Hashimoto patient had to undergo a surgery?
No, this is this case are not undergo surgery. This case are actually not, because Hashimoto's thyroiditis is treated with the medication by seeing the level of TSH level and T4 level.
And the cytology? Okay, sir, can you please, sir?
Yeah, what the new things you wanted to tell to your people? What extra knowledge you have given? Anything? Nothing. Okay.
Okay, thank you, Dr. Roy. So over to Dr. Ankita. I think we will now close the session. All the residents have presented very well, and I think they have been they have received some information from this discussion, and they can expand onto their study or add on some ancillary techniques to do a better job, and they can go on for publication of these data. Once you've collected the data, you should expand on it and you should work on it with the guidance of all this discussion that you've received, and wish you all the best. So over to Dr. Ankita, please.
Yesterday we had a elaborated discussion on the thyroid pathology and about the ancillary techniques for the thyroid pathology. It was very clearly and elaborately dealt by Dr. Indranil Chakravarti. I think we should at least follow the Bethesda system or like that.
Yeah.
Yes.
That's
And can we stamp the FNAC as the gold standard for diagnosing the thyroid pathology till now? In your conclusion, Dr. Rai,
Ma'am.
you,
Yeah, ma'am.
yes, you have written that FNAC may be the gold standard. Can we stamp it as an?
No, ma'am. Histopathology, FNAC, after doing FNAC, we can say that there are many gray zones which could not be
dealt by the cytology only.
By
Yes.
cytology only. That's why we have to need for the histopathology, and if
The
necessary,
FNAC
then
could
we
not
do
be
for
the
the
gold standard for any
Yes,
diagnostic as a diagnostic tool for thyroid pathology at
Yes,
least.
ma'am.
Okay. Thank you.
Okay, ma'am.
But you have done a
Okay, ma'am.
Okay. Thank you, Jayati, for
Thank
your
you.
kind patience.
Thank you, ma'am.
And here it was Anindita, na? No. Who has
Ankita,
come?
ma'am.
Ankita, yes. Ankita, all of you, the anchors, are doing a very good job. So thank you all.
Thank you, ma'am. Thank you, ma'am.
Thank you all the presenters. Let us join in the main hall now. Okay. Please come to the main hall. Okay. We will expect you all there.